Morning, members, to tonight's Health and Adult Social Care Overview and Scrutiny Committee. We don't have, we have got apologies for absence. Councillor Brown.
We've got apologies for absence from Councillor Mark Pentrell, and I'm deputising. Thank you.
Thank you, Councillor Brown. Councillor Waldie?
No apologies, thank you.
Thank you very much. Can I sign the record of the meetings held on the 7th and 20th of August as correct, please? Is that agreed? Thank you. I have no urgent business to announce. Are there any disclosable pecuniary interests or other significant interests and whipping? Councillor Mandarakis.
Hi, so it's not an exact DPI, but I am a trustee of the Sunlight Centre and we run a dementia cafe. I just mention it in the interests of transparency.
Thank you. It's good to get that in there about the sunlight and having the cafe. Thank you. Can I just remind all those speaking, we have a full agenda this evening, a very full agenda this evening. So can we keep introductions as short as possible? And bear in mind that members have read the papers and read your very thorough papers tonight. So thank you very much for that. So if we can keep the highlighted report at the beginning and then we'll ask the questions. Okay. Over to, is it Rachel first? We're going for you, aren't we, Rachel? The dementia update.
Yeah, wonderful. Thank you very much. So I know we'll have read the paper, so I'll give an overview before allowing us some opportunity for discussion and any queries if you have them. So dementia is very much a priority for the ICB, and during the recent restructure, the portfolio for dementia has transferred into the Ageing Well and Dying Well programme under Dr. Cryer as clinical lead and myself. This has provided a renewed emphasis on managing dementia holistically and within frailty pathways. It's also enabled scrutiny of the assessment and diagnostic pathway to identify opportunities to improve the diagnostic rate and to meet the needs of our increasing population. As a system, we're seeking to make positive changes across the entire dementia pathway and establish a revised, robust, co-produced pathway of care that will deliver a sustainable service and solution to meet the rising needs, or our rising population needs. The report details the current dementia diagnosis rate in Medway, the actions to date and the development plans that are being taken forward to support both the achievement of the national directive to achieve the 66.6% diagnosis rate of the predicted prevalence, and of equal importance, ensure that the appropriate proactive and reactive post-diagnostic support is in place, wrapped around the person with dementia and their families and carers. There are just a few things I wanted to bring your attention to. So the first is that in agreement with NHS England, our Kent and Medway ambition is to achieve 63% diagnosis rate by March 25, but then continue to improve to meet the national standard over time. There's been some challenges with the memory service capacity relative to historic backlog and demand, but we have addressed some of that, and my colleague from KMPT will describe some of the internal improvements they've been making within the memory service. Some of the increased diagnostic capacity has been inputted via recruitment of GPs with enhanced roles, and there's been some targeted work in the Medway area between KMPT, our GPs with extended roles, and Medway to Community Health, and that's demonstrated both an improvement in the diagnosis rate and a slight reduction in the waiting time. So it's really a positive start, but with more to do. The latest diagnosis rate in Medway was 61.4%, and we started in April 24 at 57.8%, so some movement in a positive way. We're working closely with KMPT colleagues, and Adrian will share a bit more about the internal work they've done. I think the important thing to draw your attention to is that the post-diagnostic support is really essential to the dementia pathway, and there is some joint funded dementia coordinators in each of the primary care networks, and they take on the role of primary contact, and help support and coordinate and wrap services around both people with dementia and their families and carers. In terms of the future, we had a system-wide event in July involving partners and stakeholders across primary, social care, voluntary sector, people with dementia and their carers. And that event identified barriers and gaps in services and proposals for improvement. The outcomes from the workshop have enabled us to develop a model of care, which is draft, which you'll find in your papers, and the plan is that we will finalise that by the end of December and look to have it in place by the end of 2025. In the meantime, we're obviously continuing to work with the Health and Care Partnership and partners to continue to chip away at that diagnosis rate and support patients.
Thank you, Rachel. Members. Councillor Wiley.
Thank you, Chairman. First, can I take a minute to just say what a wonderful visit it was the other day that members went to from both sides to the 111 first response CCAM. I'm not sure what to call the building, but the work that went on there was wonderful. So just like to say that. Thank you. I really do have some problems with this. You did mention that at present it's 61.4% diagnosing, whereas it should be 6.6%. And your wording is a significant improvement, as if you're pleased with that. Now, any improvements to be welcomed, but you're not hitting the standard that you should. And I'm assuming that's only an average. So, and even that average is only 2/3 of what you expect to. So none of that fills me with great joy, to be honest. Some other comments, if you don't mind. 5.6 shows that some of the service users, find there's lack of support. 5.9, I think it's great that there's community groups that provide support. 6.8 seems to be you did a specific amount of work to get lots of diagnoses done in a 6 weeks period. If you need to diagnose more people because they're out there, can't that work continue and go forward? And then hopefully you'd, before next year, you would be up to the expected rate. And a great bugbear of mine is at 6.10, you say you can upskill GPs and get GPs to do more work when we have a fifth less GPs in Medway than the national average. We're still, 26 GPs less than we had in 2017. GPs have enough pressure on them already. And I think in 3 different reports tonight, they're saying they're going to give GPs more work to do. So great in theory, but we need the GPs before you can do that. Those are my initial questions. Perhaps I'll come back later. Thank you.
Lovely, thank you. Yeah, no, not wanting to have sold the increase maybe, but I think it's positive that after a long period of us being static or having reducing diagnosis rates, we are finding that the work we're doing is starting to make a difference. So it's absolutely nowhere near where we would like it to be. We recognise that, and that's what we're working towards. But I think the signs are positive. And if I oversold that to you, then I'm sorry. But I do think it's still a positive move, because we're finding some things that we're doing that are working and making a difference for patients. In terms of the post-diagnostic support, you referenced the feedback from the patients. That was the feedback from the patients before we put in those dementia coordinator roles. We do have an evaluation of that, which we haven't included in the papers, but I'm very happy to circulate that if you'd like to see some of the difference in patient experience we're seeing after the implementation of the dementia coordinators.
Please, that would be helpful.
And yes, in terms of continuing the work, yes, we have had a push and a piece of work. That work isn't stopping. We're continuing to move forward with those those pieces of work. So yes, we won't be waiting to next year to see the continuing increase of that rate. We're continuing down that road. I don't know whether Rakesh wants to comment about the GP's workload.
Yeah, sure. So
Sorry, we've got something wrong with the mic there, I think. When you press the red light on, just leave the red light on. It's gone off again.
I think that's on now, yeah. So thank you very much, Councillor, for your invaluable comments. I'm a GP by background myself, and one of the things we need to recognise with dementia is that dementia is preventable in many cases, so I think we need to do a lot to see how we prevent it, first and foremost. All the vascular risk factors will help dementia, so we need to do more as a society. The second thing is that dementia has a lot of stigma, and that's one of the other reasons why the diagnosis rates can be challenging. So we need to raise awareness why people need to come forward and what we can do with them. So this afternoon, myself and our Senior Programme Manager, Wendy Lakin, were talking to our Brighton colleagues, where they have established a GP-based dementia diagnosis service over the last 12 years. So dementia is a long-term condition like any other long-term condition. It just so happens that historically we have worked with our mental health colleague specialists to make the diagnosis. And what we are hearing is that if you look at the whole person and help to diagnose this in the community, in combination with wider professionals, including our mental health specialists, we will increase the throughput as well as support the diagnosis and the management better. So I take your challenge that we don't have enough GPs, but we are also working very hard with our universities and our wider systems to see how do we train more GPs and retain them. But I really want to say a majority of these long-term conditions, as we had our Allied Healthcare Professionals Conference whole day today, is not just about GPs. It's about the wider teams and the partnership with our communities. How do we do this better?
Thank you. Yeah.
Councillor Nain.
Thank you very much. On page 5.6, section 5.6 on page 30, you said service not equally distributed across the county. So which part of which district within the county do we think they are not having much of the services when it comes to dementia, being able to identify early people who are suffering from dementia? Which area or which district have the lowest rate of being identified?
Thank you, Councillor. So one of the things we are doing is to try and understand within each primary care network, each locality of practices, what the different dementia diagnosis rates are. I'd have to get back to you with the specifics looking at which PCNs they are. But you are absolutely right. That is how we want to identify not only how we give more support. So, for example, working with my colleague here, Adrian, with KMPT, what we want to do is go to those areas which are either low in diagnosis or most needy in terms of the health inequalities, and then provide them with the best support to diagnose first. So that's what we're going to do.
Thank you. Councillor Cook.
Thank you. Just a brief question and comment, really. I was really drawn to section 5.12 and the community work that supports this. Really pleased as a ward councillor in Weedswood and Wayfield. Looked at the nets mentioned. I think they're a place to do fantastic work. There's also an Anna chaplain that has come forward to work really closely with us as councillors as well. So I think this is a really brilliant example of the community working with our whole health service. I'm a little bit concerned, though, about how reliant we are on volunteers and on the wider community, and how that might mean that it isn't a kind of spread evenly and fairly accessible offer for the whole of Medway. So how do we work with the fact that so much of this kind of care is voluntary organisations, and how do we make sure that there's a sustainable system for everybody? Thank you, Chair.
Thank you.
So once again, thank you, Councillor. So on last Thursday, we were very privileged to be in London as a South East team with our Chief Medical Officer, Dr. Kate Langford, as well as our community CEO, Mairead McCormack. And one of the things we have to recognise is that we're going to age and live longer, but sadly, we're going to live longer more with ill health. And that applies to all conditions, all long-term conditions, of course, including dementia. Excuse me, if we're going to overcome this challenge properly, we're going to have to do a lot more as communities and as a society to see how we can prevent some of these long-term conditions. Having said that, we can't prevent everything. And the only way we're going to be able to manage better is to how do we empower the individual and their families the best way we can so they can become expert at what they can do. But also, how do we move more of our services into the communities? So one of the things we want to develop at pace in Kent and Medway is what we call complex care integrated neighbourhood teams. These are teams that are not just going to be about health. These are teams that are going to be empowering, supporting our communities, how to keep well, what should they do in terms of physical and mental health, but also how to proactively try and find a way. So this is where we need help from you. You know, are we ready to build age-friendly communities? Are we ready to have people who may have some degree of dementia, but they are living in an environment which is supportive? So this is not a short fix. This is a long-term fix, but we want to do something this winter. And with the help of our CMO and our teams, there are a number of winter schemes that are designed to exactly do what you are saying. How do we support in partnership? But in short, we can't solve this just with health. Health is 20%. 80% of this is the wider social determinants. So it's about how do we build the future better.
Okay. Councillor Campbell.
Thank you, Chair, but my question was asked by Councillor Cook. So.
Councillor Jackson.
Thank you, Chair. Thank you for the report. Dementia is quite close to my heart. I just reading the report's really good with the post-diagnostic help, but I'm aware, and personally I'm aware of a few cases where people got diagnosed over the phone in lockdown, and they're only just having their assessments done now. And I'm just wondering, that was just three cases that I know about. I wonder if this is a bigger issue and there's other people that are being missed through the gap and still haven't had their assessment. So they've got their diagnosis and the GP knows it, but they haven't had their assessment done. So everything was just done over the phone, so they haven't had face-to-face. And I just wondered if that was a problem or a gap that you knew about, or if it's been plugged.
Sorry, I'm just going to bring my colleague Rachel in as well. So I agree and sympathise with what you're saying. The pandemic meant we had to work differently, but this is exactly why we feel that conditions like dementia should be managed in any individual as a whole person, right? So depending on where they are, there is clearly a need for dementia to be looked after as a part and parcel of primary care, my GP colleagues, myself, but also the wider community services and our frailty services. And I think Rachel and Adrian will have comments to make on this as well as to how we catch up.
Rachel,
Yeah,
I would bring Adrian in on the next item.
Yeah, I'll bring Adrian in first and then I'll follow up.
Well, I'd bring him on the next item. So did you want to hold that thought, Adrian, or do you want to? Okay.
So mine's really quick, and off the back of the DPI, you'll know why I'm asking, but how would people who are running dementia services make themselves known to those dementia coordinators?
So the dementia coordinators sit within each of the PCNs, so all of the GP practices should be aware that they exist and be able to signpost.
The ones that aren't connected to like GP services? So obviously, like I said, I know of one that runs from the sunlight that happens to have a GP surgery, but if they're not running connected to a GP surgery, how would the dementia coordinator necessarily know about it?
So thank you. So our dementia coordinators are working within the primary care networks, and the idea is a group of practices, a bit like the integrated neighbourhood teams we're talking to develop even further. And within that PCN practices, all the GPs, all the other professionals as well are aware of those coordinators. But clearly, if there is any gaps, if there are any areas where there is that gap, we would like to know what they are so we can make sure that that gap is filled. But that's how they function normally. So the KMPT colleagues, the GP primary care colleagues, the community services will all be cited to these coordinators, and they're able to work and navigate through them.
I'll just bring in Health Watch Medway.
Thank you, Chair. There was a lot of talk about 20% health, 80% is everything else. And there was a lot of talk about, are we ready to become dementia-friendly Medway? So my question is there any joint work being done with the leaders who are putting up together a local plan? Because a lot of infrastructure needed here probably will have to come from somewhere else.
So I think we have a dementia oversight group that's a system-wide group that's chaired by Rakesh. We have colleagues from across the system, health, social care on that group. So I think that will be the place where we can start to kind of gather that momentum to take those things forward.
Thank you, members. I think for me, I mean, can I just check how many dementia coordinators are there in Medway?
I think it's in the paper. There's one per PCN, so however many PCNs you have that amount of dementia coordinators.
Do you not know how many PCNs we have at the top of your head in Medway?
I don't off the top of my head.
So we've got, sorry?
43.
Now, how many in Medway?
I'll have to check for you.
Okay.
I think it's
If you can check that one out for me and then come back to me, that'd be great. Obviously, for me, the points around the dementia cafes and the volunteers are key. They are so important. Our community, the community volunteers we have do back up the system, and I understand what you're saying with regards to we've got to get more dementia friendly and more aware. I suppose for me, of course, there is an upturn here with regards to we've gone up a bit in our diagnosis rate, but it's still poor. When we're reading the waiting list is 2,500 people, and the average wait is 20.1 weeks. It's really not good enough, is it? And I know you'll agree with me. I'm not criticising you individually, but the system is not set up to help with what we want to do. And I'm sure, I'm not medically qualified, but the longer we wait to actually diagnose somebody, and the longer it is in the system, surely interventions could have been brought in, if possible interventions could have been brought in. And I know Adrian will touch on that in a moment when we get there, but Adrian knows I'm also going to say with regards to KMPT, it's not good enough as well. So the questions you're being asked, I think, is yes, you said in the beginning of your paper that our growth figures are going to be massive. 46.2% growth by 2030, and we're not prepared. I'm not asking you both to prepare that, but the whole system needs to really sort itself out, doesn't it? Because we're hearing everywhere dementia is the biggest issue for our older generation now, and we just don't seem to be. We're talking about people from national and everything, and we talk about investment. Where's the investment going? Because we don't seem to be dropping these waiting lists at all significantly. Before I get the challenge, I'm going to say significantly, because I know they were a lot worse before. But it is disappointing. And I think what Councillor Wadi was saying is you're right about GPs, but I suppose it's about the pressure they're under already about upskilling GPs with extra responsibility. Are we prepared for that? I think they're so your thoughts on where we are with regards to the waiting list and whether it's going to get better, and also I'm going to touch on Councillor Whitey's comments again. From a GP point of view, our GPs are struggling. How are they then going to take on extra responsibility?
So thank you so much, Councillor, and we take all of these comments very, very seriously. So let's just reflect on it, right? In terms of the dementia, if we look at our care homes in Kent and Medway, we have some of the largest number of care homes. And within our care homes, up to 60% of those individuals are likely to have cognitive impairment or undiagnosed dementia. We also know that dementia can be quite insidious and takes time for people to present for the stigma it sometimes has and so on. So the way we want to approach it, working with Adrian and working with our wider colleagues, is to start developing pathways in the community which will target the care homes, so all frailty practitioners and all other services in the community will be part of that diagnosis. That is one large number of patients who will be benefiting from that. The second part of this is, how do we increase the diagnosis rate in the community? And that is going to happen by building. So we currently have 9 GP specialists. We have many more consultant psychiatrists and other healthcare practitioners involved in this. And what we want to do is to use the expertise we have via the multidisciplinary teams to increase the throughput. So for example, if the GP colleagues were able to request the blood test and do the scan request by the time that the patient is waiting to be seen, this will increase the number of diagnoses we make. So there are a number of things we need to do to try and increase the rate of diagnosis. But equally, I can't emphasize enough that we need to try and take every effort we can to see where we can prevent dementia, but also how do we work as a wider communities to try and help individuals with the whole challenge rather than just the diagnosis.
You know, I do agree with what you're saying, but the responsibility of diagnosis and responsibility of treatment is down to the healthcare professionals, okay? And I think sometimes, and I know you're very aware of it, I know, of course you are, but I've got to say it again, dementia, when the care home is one thing, those in the care home, they're probably being cared, they're at that upper end of, you know, the quartile with dementia. There's others on the lower age range that are living with their partners and their families, and the whole family are experiencing that breakdown with regards to their dementia diagnosis. And the impact for 20 and 21 and 22 weeks on that family unit is significant. And I know I'm teaching you to say, okay, because I know you know that. But do you understand the frustration? I'm just saying, I love it when you're saying to me about it's got to be in the community, but I suppose we've got to see the plan. Because if we're throwing more and more, which Adrian will get in a moment, throwing more and more people at this, but we're not really dropping much as what you would want to see, where are we going to be in, you know, for that vision you have is right. By 2030, it's going to be worse, and these waiting lists are going to be more, aren't they? I know you would like to sit here and say, no, they're not, but they will. So whether you're waiting for a plan from national or waiting for a plan from commissioners or whatever, it's just, you know, it's pretty sad to see that, you know, I know especially for you from medical, you know, you don't want to see families struggling with this, and I just want to emphasise it's the whole family that struggles with this. Sometimes elderly husbands or wives that are at home and have had a lovely long life, but then struggling at this end with no contact or no support on many occasions. So I just wanted to make that point, and we'll probably come to it again in a moment, Adrian. Councillor Campbell.
Just a quick note, I think there are 10 PCNs in Medway and Swale, so, but I think 2 of them are outside of Medway. So anyway, that wasn't. I move that we note the contents of the report and note that in August 2024, Medway achieved a significant improvement in the dementia diagnosis rate to 61.4%.
And we also want, we're requesting that dementia coordinator review paper. Was that Councillor Wiley?
Please. And can I suggest that we look again at the task group we did on dementia and see what the council offered to do, and over the years that seems to have not been happening, as in I remember Councillor given dementia friendly awareness, course which took an hour or two, but that doesn't seem to have happened for the last considerable number of years.
Yep, so I think Terry's got a Councillor Campbell, so I think it's just about a look back at our task group and see what the reflections on that. No. We'd love you to, but we won't make you do it, honestly.
Right, thank you.
Thank you so much. Can I just ask for members to second that? And is that agreed? Agreed. Members? Thank you very much. Thank you very much. Thank you. I know you're going to stay for a moment while we talk to you. Adrian, over to you.
Thank you, Chair. Good evening. We are presenting today the three areas we discussed in the agenda setting meeting. One on branding and identity, second a follow-up on Ruby Ward and the transportation particularly, and that was also followed up from the last HASC with a briefing to members over the summer as well. And then finally, the internal the internal work that's underway with regards to memory assessment. In terms of branding and identity, we've been working on this for well over a year now, and today I'm joined by Kindra Heitner, who's our Director of Comms and Engagement, who'll be happy to take questions on it as well. We've done over 700 hours of engagement with patients, carers, and with our staff and internal and external stakeholders, including HASC, with regards to our brand and identity. And what was quite clear is patients and loved ones did not really understand what KMPT provides. So we have proposed, and KMPT's board have approved the intention to move to Kent and Medway Mental Health NHS Trust, subject to NHS England sign-off, and that will be aiming for going live in April of next year. The second part is a follow-on from our previous HASC discussions on the new Ruby Ward in Maidstone, and I'd point out that we as an organisation operate a system-wide bed profile. And so the paper outlines how we've been supporting patients and carers with regards to access, predominantly from Medway to the new Ruby Ward at Maidstone. We've contained in the paper information on our volunteer driving scheme, as well as noting that demand for the dial-a-ride that we set out on page 32 of the initial consultation to Ruby in 2021, that has been minimal, but we do continue to review that. We've also made some new initiatives in the last few months in terms of relaxing visiting, so that we've now got open visiting on the majority of our wards. And I think that's really important because obviously people who want to take advantage of or who need to use public transport, particularly with concessionary travel and things like that, may be somewhat limited with the less flexible working times, with the less flexible visiting times. And we've had positive feedback both from patients and relatives on that. The paper also does detail with regards to the small number of Medway patients that were admitted to the Ruby Ward that was based at Medway, and that there hasn't been an increase since the new Ruby Ward opened, and they are very small numbers, but we will continue to monitor that, and we continue to offer patients and relatives all the assistance that they need with regards to locations, not just on the new Ruby Ward, but across Kent and Medway sites. And then finally, we've outlined the KMPT's internal response to the memory assessment service. We want to improve the memory assessment service in three phases. The first phase we've been working on since June, and that's a standalone, separate from our previous community mental health of older people's teams, a separate dedicated 6 memory assessment services across Medway and Kent, so that we can standardise how we assess patients, and give them as rapidly a diagnosis as possible. The second bit will be working out who can also diagnose, and that it doesn't just have to be a consultant psychiatrist, and we're about to enter into that second phase in the next few weeks. And the third phase, obviously Rachel and Rakesh have already pointed out with regards to working at system level, with regards to that 3 levels of intervention, with regards to very rapid assessments for those patients who are in nursing homes and other areas where the diagnosis of dementia is very obvious, and then more moving on to the GPs with enhanced roles before then the final layer, which is the memory assessment service by multidisciplinary teams within KMPT or consultant psychiatrists within KMPT. Before I pause, I will touch on a couple of questions that were raised during Rachel's paper with regards to the access question that was asked. We do know that Royal College of Psychiatrists put out a national audit of dementia earlier this year that did point out that there was on average a 15-day discrepancy between those in terms of access for memory assessment services for those in more deprived areas compared to less deprived areas. And as part of our internal work in terms of health inequalities within KMPT, we're currently working with health information against in Sussex to establish a dashboard, particularly on access around dementia, to make sure that those areas, those postcodes that are associated with more deprived areas, we will work on trying to improve access for those particular patients to help that. So I hope that provides that answer. And in return, in terms of the COVID question, we eliminated, as far as we're aware, we eliminated our COVID backlog back in October last year. Nationally, memory assessment services stopped during COVID, and we had a significant backlog that we have been working on. And we have been also working on making sure that the data that happened over that period has been accurate. Now, if there are individual cases, I'm more than happy to take that back with that to our Chief Medical Officer so we can actually look on that. And I think, you know, those small number of cases will need to be looked in case by case to make sure that we're getting the right diagnosis for those people as well. I'll pause there, Chair, and happy to take any questions.
Thank you, Adrian. Councillor Wiley.
Cheers, thank you. As you know, I've been for a long time very annoyed because I don't think the transport provision is what it should be. By your report and by what you say you're doing, I'm surprised that you aren't getting more call for more use, but you know, if you're asking people, it's difficult to do more than that. I still think we need the provision within Medway because I do think we've got the need, but you know, that's not going to happen, so I've got to accept that. From this report, and you're changing your name, I couldn't believe the amount of money that's costing. And personally, now I'm dyslexic, but whether you call something KMPT or KMMH is equally as meaningless. If you put the full name on there, you know, that has mental health written in it, then people will understand that. That's, you know, that's not rocket science. To me, that's obvious, but they're my only comments. Thank you, Chair.
Councillor Crozier.
Yeah, just a simple question for me. I don't understand transport and memory assessment services being, you're talking about both. Can you tell me where the memory assessment service is provided?
If I take that, so we have 6 memory assessment services across Kent and Medway. One will be within Medway, which is, I believe is our Britton House site in Gillingham, and then we have 5 others across Kent and Medway.
But only one in Medway?
Yes.
Yeah, I'll come in on the cost question, and I think, you know, it's a really fair challenge, and particularly at the moment, you know, when we're obviously heavily scrutinising and looking at our, you know, where we spend money and demonstrate value for money. When we set out on this work, actually, we didn't set out to change our name. What we set out to do was really understand the perceptions of everyone who uses our services, who works within our organisation, and who we partner with to deliver services, to get a sense of what do they think of us. And as Adrian said, we did about 750 hours of listening, and we did that really because we know that we need to improve engagement, particularly amongst our staff, because engaged staff leads to better patient outcomes. And actually what we heard really loudly through all of that engagement was people's first impression of us is one of confusion and lack of clarity. And there is a real need for us as a public organisation to have that clarity and really explain to the public and our staff who we are and what we do. So there was a real drive there from all the audiences that we engage with to change our name as part of looking at our identity. And I think there's also, for us as a mental health trust, a real sense, particularly amongst our staff, of being proud of the expertise and what we do and trying to tackle some of that stigma. So we couldn't not listen to what people had told us. What we've then done is gone back and engaged with all those audiences to say, you know, does the proposed name work for you? Is it clear? Do you have that clarity? And through all of that engagement, actually, it's been overwhelmingly positive. I take your point about the abbreviation. I think, and I would say this as the comms director, I think we overly use abbreviations. And actually, when we talk about working where we do, we talk about working for the Mental Health Trust for Kent and Medway. And my final point I would just share is, you know, the challenges that we did have on the name was actually, can we simplify it further? So we even had quite a lot of staff and patients say, can you just call yourself the Kent Mental Health Trust? But obviously we will absolutely not, and all councillors I'm sure will agree, that we very much see this as Kent and Medway Mental Health Trust.
Thank you. Thanks very much, Kinja. I mean, I was part of that one of those phone calls. And actually, I'm slightly disappointed because you had an agency that was very forward-thinking, and I thought we was going to come up with something really different. And, you know, I've got to say, and please don't, especially those in the audience as well, you know, I think the health professional are the worst with their acronyms than anyone I know. So, you know, I mean, we've got a local hospital that's called MFT. I'm sure they'd rather be called something different. But you know, this will end up being an acronym, without a doubt. And you know, okay, it's got mental health in, and you know, that's what your bread and butter is, and that's what your job is. So at least we've gone back to some form of that. Can I just ask about the cost though? So the £250,000 cost, is that coming from your reserves?
Thanks. No, so that's within our existing envelope. And actually what we're doing is taking a very kind of pragmatic approach to how we deliver these changes. So we're utilising existing things that we already needed to do. So for instance, our signage on a lot of our estates is actually in very poor condition, needs modernising, but also placing in areas where people can actually follow, because actually what we heard from a lot of patients and families and loved ones, and you know, we've just been talking about those with dementia, it's very confusing, some of our sites, actually finding buildings. And so we'd already had plans to kind of look at our signage, things like decorating programme, you know, they're all within our existing plan. What we want to do is just be really pragmatic about it. Other things such as like our external website, we need to update that. It's very old. We need to be much clearer about our services, how people can navigate our services. So that was already in our plan over the coming years. So again, we're just taking those opportunities to do it.
So when you say it was in the envelope, it was something that the board had budgeted for, not just the name change, but you was going to be doing a whole programme of signage change anyway.
Absolutely.
I think that's where I'm coming from about when you say it's already in the envelope, the money in the envelopes come from hospital services, obviously. So it was a budgeted amount, is that correct?
That's it. And,
okay.
And we've kind of overly, I would say, in terms of how we've kind of costed it, we've been quite generous in that costing. We would hope to bring that in within that, and we've shared that with our board.
Thank you. And Adrian, just finally, you know I'm going to ask you this because you know I will. On a scale of 1 to 10, how satisfied are you with the dementia services, the memory services? You know, you're saying again 189.9 days. We've got 21.1 weeks, or I don't know what sounds better, but you know, it's poor, right? You know, we're not getting there, are we? And now you're telling me the phases are coming in. We've got 3 phases coming in. Are you going to raise our expectations, say, by the 3rd phase when that comes in? Are we going to be at the 61% diagnosis, or are we going to be at 70, 80% diagnosis? Where are we going to be?
So I'm not going to be able to give you a trajectory because I think, you know, there are a number of things that affect that. Plus, as we say, you know, nationally, dementia is an increasing issue for all of us, particularly with new drugs coming online and things like that. So I think nationally and internationally, we are going to be seeing some significant changes and challenges around dementia that are out of the scope of, obviously, Kent and Medway on our own, but we can try to help and contribute to that. Yes, you're right. We have made some inroads. You know, we've cut the average waiting time since June by 35 days, but that's still 154 days that loved ones are having to care for patients, not knowing whether they're going to remember this Christmas or next Christmas, and that's not that. You know, I will not settle until that is as low as we can get it. In terms of nationally benchmarking, currently, if you look at the Royal College of Psychiatrists audit for last year, around 10% of patients are diagnosed within 6 weeks. As of August, we were looking at 16.9%, so slightly above average, but that doesn't stop us. You know, we're starting to see that momentum, we're starting to see that energy within the organisation and at the system, because we want to be, you know, we want to be leaders in how we sort of really tackle the diagnosis piece, because that's only the first part of dementia care to then tie people into the right services.
I mean, just to be clear, just before I finish, I wasn't just saying Kent is the worst. I know everyone across the country needs to back up their ideas and buck their game up when it comes to dementia. You know, we all seem to talk the talk, but we can't actually get out there and help those individuals. But you said about your 3 phases, you must have a target at the end of your 3rd phase. So when I was saying to you, I know you said you can't tell me where it's going to be because of the drugs, but when you bring in these 3 phases, you must have a target on your 3rd phase of where you would hope it would be.
Yeah, absolutely. So last year I set out with regards to what our strategic ambitions are for the organisation, and we want to see that 95% of patients who are referred into the memory assessment service within KMPT are seen and diagnosed within 6 weeks. Now, that is a big ask. I know that's a big ask, but I think that needs to be a significant challenge to represent the challenge that is happening within the wider health, the wider healthcare economy for dementia. And I think, looking at the trajectory, Rachel and I are working very closely with Rakesh with regards to what we can do to get us to that 63%. I don't think that 63% is unachievable by April, and we will do everything we can to get us to that. The next stage will be to get to that 66.6%, and we will not stop until we get there.
I'll be excited to see when you're next back, whether you'll be calling it KMPT or KMMH. We'll see where we go. Vice Chair, Councillor Brown, did you want to come in and say?
Thanks for the report. Adrian, I'm a little bit confused that in 5.10, the financial modelling for this new approach is in the progress with timelines to recruit to the new model still being agreed. And it's anticipated this model will begin testing in Q3 of this year and be refined before a rapid rollout. And then we come on to what I would say are challenging deadlines. So if you haven't financially modelled it and you're going to rapidly run it out, how can you actually marry up these things that I think in 5.10 and 5.11 and even 5.12 are challenging?
Can I just check which pages you're on? I don't have a section 5 on my report. I'm not sure whether that's the previous report.
My fault.
Thanks,
but the point is that if we haven't got the financial modelling done, I think some of your targets might be challenging. It's a comment.
So we are working within our financial envelopes, obviously, and what we're doing here is working collaboratively. So if we can free up, a very valuable resource in terms of consultant psychiatrist time, and use multidisciplinary teams to do that, then we need to look at where we then utilise that that extra capacity that we've freed up with regards to the consultant time, and we've already had conversations about how we do that. So we are doing some modelling with regards to what we need and where that money needs to sit, but we are talking across the system about how we share that and how we work within the financial envelopes that we are currently existing in.
Thank you. Vice Chair.
I move that we note the report.
Seconded? Agreed, members? Agreed. Thank you so much. Thank you very much for your time. Let's hope for some good news next time you're back. Thank you. So we've got Marie now. Marie coming up to the front. Hi, Marie. Hi there. So again, as obviously members have read the very good paper that you've given us. So if you want to give us some highlight, that's great of some points.
Thank you very much. Good evening, everyone. I'm Marie Hackshaw. I'm the System Programme Lead for Learning Disability, Autism and ADHD across Kent and Medway. My post is a jointly funded post across Medway Council, Kent County Council and the Integrated Care Board. I'm here this evening obviously on behalf of the Integrated Care Board because it's a health-led pathway that I'm discussing, but it's been developed in partnership with colleagues from across the two councils, people with lived experience and our current providers as well in terms of the development that we're taking forward. Just a couple of key points. Obviously, you'll see from the paper that for neurodiversity, particularly autism and ADHD, demand has significantly increased in the last 2 to 3 years. This is a national increase. It's not unique to Kent and Medway. We're following the national profiles in terms of that demand increase, both in children's services and in adult services. The paper this evening refers particularly to adult services, but I'm aware that there are issues around the children's pathway as well. We're working to try and move away from people needing to access an assessment and diagnosis in order to access support. So to be a support-first, needs-led pathway, that's very much what the paper is describing and the pathway development is describing. It's important to note that all the services described in the pathway are already in existence. They're just delivered in lots of different spaces. So we're trying to bring them all together and have a more cohesive pathway for people to access. And so we're not proposing any material change in services or any reduction or negative change to people by a result of the proposed changes to this pathway, but recognizing that the demand significantly exceeds the capacity, so there will remain challenges to delivering to the population locally. Thank you.
Thank you, Marie. Members. Councillor Cook.
Yeah, thank you. I just want to pick up on something you've just said, and I think you're referring to something that's on page 53, page 54, around the move from a focus more on the kind of assessment diagnosis to support even in the waiting. And I just want to be open. I don't think it's a DPI, but apologies if I've missed this. I've got children on the children's pathway myself, and we're having this exact conversation. And it feels, to be blunt, a bit like a way of covering for the fact that we can't get the diagnosis done quickly enough. And there was a really big discussion between accessing support when you haven't yet had somebody verify that that's exactly what you need. And it feels like support then becomes a self-service when you haven't actually sat down with a doctor and them say to you, this is what's going on in your brain. So I'm a little bit concerned about the statement you've just made, and then seeing that in the report around almost it feels like more of a moving people towards accessing support instead of earlier than getting them that kind of diagnosis first. And so that just raises some concerns for me. Thank you.
Thank you. It's important to note that you can look at neurodiversity from two lenses. One is a medical disorder that requires a diagnosis of a disorder and therefore a treatment, or you can look at it from a social model, which is that a large proportion of our population are neurodivergent, and therefore it's a normal curve within the population that we have, and therefore it's actually identifying and helping people to self-manage the way their brain works, for other people around them to understand how their brain works, and to ensure that, particularly in education, support is available to enable children to access education, social environments, without necessarily having a diagnosis to drive that forward. Because a lot of the support that one gets following a diagnosis is the same support that one would get without a diagnosis. So it's not pertinent that you have a diagnosis. We're not wanting to shift everyone off a wait list. We recognize that diagnosis is really important to people and self-identification, self-knowledge is really important. But we recognize that at the moment the waits are significantly long. We don't have the resources to undertake all of those assessments for all of those people. So we need to try and ensure that people have access to support while waiting for assessment, but also access to support if in fact the reason they were coming for assessment was to get the support in the first place, not necessarily because they want a diagnosis. So it's trying to manage both ends of that pathway as best we can.
Thank you. So I think the kind of question in terms of Medway is whether this is about the fact that we just don't have the resources to offer diagnoses, in which case we're asking people to self-refer almost, or whether this is a difference in what you described at the beginning of what you just said around the kind of fundamental understanding, the research behind what provides the best support. So is this a way of getting more people seen because we can't give everybody the diagnoses, or is this in response to a more researched understanding of what autistic people need? I'm not quite sure which of those two drivers it is, if that's right, just to come back, Chair. Thank you.
Yes, thank you.
Thanks for your question. This is similar to what it used to be in schools around dyslexia. Some parents would want the diagnosis, but teachers soon learned if they taught that child as if that child had dyslexia, the outcome for that family may be what they wanted all along without the diagnosis. Some parents would insist on that diagnosis, others would say, no, the outcome for our child is as we would expect, and thank you for your support. So it's not, it's as Marie's saying, it's horses for courses. I would like to assure you that it's not all about a long waiting list for diagnosis. It's a bit more nuanced than that, and I'm grateful that Marie is bold enough to give that a go, if you like, and the whole system needs to give it a go. But obviously this is up for review, constant review, and it doesn't prevent diagnosis. I hope that helps.
Councillor Jackson.
Thanks, Chair. This is what you just said is, as a mum with special needs kids, I think that is a brilliant way to go forward. I just wanted to ask if FASD was being added to the autism and the ADHD pathway, because the commissioners in the quality standards, nice quality standards, we were supposed to have a pathway for FASD. And we said that we could use the neurodiverse pathway. And as a lot of children with FASD have ADHD and autism diagnosis, I just thought, are we adding FASD to this pathway as well?
Thank you. So FASD is fetal alcohol syndrome disorder, if I remember rightly.
Fetal alcohol spectrum disorder.
Spectrum disorder, thank you. It's a little while since I... so we've had lots of conversations in the children's space about that, because our appetite in the children's space is to ensure that neurodiversity and it's all-encompassing. It's not just autism and ADHD. There are many other aspects of neurodiversity that people experience. So that is certainly part of the conversation in the children's. We've not had that discussion in the adults because it's not been raised, but I will take that away and see if there's a need for us to look at that from an adult perspective. And this pathway is for adults at the moment. Thank you.
Can I just come back? Yeah, I mean, a lot of adults are now being diagnosed with FASD after struggling for years. So I think it's something that needs to be brought up and discussed. Thanks.
Councillor Wildy.
Thank you. The report states that there's been a 600% rise in specialist service, etc. And yeah, but the chart doesn't show those numbers. Can you explain that? And You're asking whether this is an SV or not. It seems if you're changing providers, you will be changing where the services are provided from, and the people doing the services will be different people. So can you talk us around that?
Thank you. Yes, the chart in the paper, which has information about the number of referrals received into the service over the last 2.5 years, is not complete. Sorry, I should have made that clear in the paper. So because of the demand on the service, they've had over 31,000 referrals in total in a 2-year period. They're still processing referrals through that at the moment, so our data is lagging. So from the data set that I have, we have about 7,000 Medway people on that waiting list at the moment for both ADHD and autism. So that's in the body of the paper. Based on population data and based on prevalence, which is around 3 to 4% is anticipated, then you would be talking about 8,500 people within Medway accessing the services in some format over a period of time. We anticipate approximately around 1,250,000 referrals into that part of the pathway on an annual basis from Medway. That's the numbers that we're working with at the moment. In terms of the providers available, so Kent Community Health is the lead provider for the service provision at the moment. They've served notice and that comes to an end at the end of March next year. They are the provider for diagnostics, assessment and post-diagnostic support. We, under the new regulations, under the new procurement regulations since January this year, because this is a right to choose pathway, so people have the right to choose which provider they can access for their mental health provision, we will be undertaking reprocurement through the right to choose procurement route. So we will have a larger number of providers available who will be contracted with the ICB to provide that part of the pathway. But we will have greater scrutiny and oversight of those because at the moment we don't have any control over right to choose. So it will give us greater assurance that what we're asking be provided is consistent across all parts of that pathway, including arrangements around shared care, post-diagnosis, particularly for ADHD medication with primary care colleagues. In terms of the community offer, and the intensive support offer. The community offer is currently offered by a number of services and we're looking at bringing that together and investing some additional resources into that community offer. And the intensive support service, which is for those who are autistic, who have a significant need, that remains the same. It'll be the same provider locally. So services will continue to be delivered locally. There will be an expectation that those providers will have a footprint in Kent and Medway for residents. For many, though, particularly around ADHD, diagnosis and assessment, that's currently undertaken virtually, so through online processes. But we're looking for them also to have a presence locally for patients to access if they need a face-to-face appointment.
Can I come back? Yeah. So with the diagnoses, you'll be using many more providers. Will they be private providers, I take it? Will they be of a size that you'll be able to have proper oversight, or will some providers be doing such small numbers that they might slip under the net? Can you give me some confidence in your oversight?
So there is an accreditation process that any provider who wishes to undertake this pathway delivery for us will have to go through, and that's a process that the Integrated Care Board has put in place, and we'll be following that for all right to choose providers. So that will allow us to have that scrutiny and oversight and assurance that they're meeting all the quality and productivity requirements that we have for that pathway.
Councillor Medway.
Sorry, I've had laptop issues. My desk is all over the place. So there was, on the referrals bit, there was quite a discrepancy of the genders. So there was quite a lot more girls referred than boys. I wondered if that was standard and if there was a particular kind of pathway that they were more likely to go down. And then the other one was just how well linked this would be to mental health services, because obviously adults that are diagnosed later in life are quite, I don't know what the word is, but it's more common for them to then also have mental health issues. I just wondered if you connected the links. Thanks.
Thank you, yes. So the referrals related to females, women, is significantly increasing and has been increasing since the pandemic, again, because people have become more aware that autism, ADHD are presentations, conditions that women have as well as men. Historically, it's been predominantly diagnosed in boys, but that's because they tend to present in a different way, and it's been seen as a male, predominantly male condition, but in fact it's not. In fact, we know that the research is telling us that many more women and girls also have neurodiversity, neurodivergent conditions. So I think that's why we're seeing that escalation in demand from women as people become more aware. In terms of, sorry, I've forgotten the second part of your question, apologies.
So it was just how well linked it is to
with
kind of mental health services.
Thank you, apologies, yes. So you're absolutely right. From many individuals coming through to this pathway, they also have a co-existing mental health need that they may be accessing support for. So we're working very closely with colleagues in Kent and Medway Partnership Trust, KMPT, who lead on the mental health pathways to ensure that they are dovetailed so that people can access both at the same time, are not disadvantaged for being neurodivergent or autistic or having ADHD in terms of accessing mental health services.
Councillor Campbell.
Hi. I had a question about the waiting times. It's quite scary to read that people have to wait 7 years for ADHD assessment and up to 2 years for a medication review. I mean, how bad is that? How does that compare against other parts of the country? Are we just in really dire straits, or is this about indicative? And the second question I had was about KCHFT, another acronym, mouthful. So it looks like they basically wanted to jump ship, and there have been some kind of negotiations to keep them on, and now they've agreed to stay till March 2025 until you can get new providers in. How resilient is that? Like, what's the background? Can you reveal that? And how resilient is that relationship until March 2025?
Thank you. So the waiting times are significant, and as you say, it's up to 7 years for people who, if you were referred today for an ADHD assessment, and that just reflects the significant demand that the service has experienced beyond what we were expecting. We were expecting to see growth, but we did not anticipate, nor did anybody in the country anticipate that level of demand. So we are working hard to try and ensure that the people on the waiting list who have the greatest need are seen in as timely a manner as possible. So those currently being seen have waited 2 years. So we're trying to work to reducing that wait time and to make sure that people are seen in as timely a manner based on need rather than based on chronological entry into the pathway. In terms of medication reviews, yes, 2 years is not acceptable, and it's the area that I'm most focused on because we need to bring that wait time down significantly. There are many factors that play into that in terms of the different parts of the pathway and how they interface. So if we can get that more streamlined, that will work. But we are putting additional investment into that part of the pathway with KCHFT, Kent Community Health Trust. We're also working with colleagues who have specialist knowledge in this space in primary care to improve the interface with primary care colleagues as well and the pathway there. And we aim to bring that waiting times down significantly, again, ensuring people who have the greatest need are seen in as timely a manner as possible. So we're working to do as much of that as we can before the end of March so that we're in a better position come the new contract. In terms of KCHFT stepping out of this space, they understandably felt that the contract was not fit for purpose because the demand significantly increased beyond what they were expecting to have to deliver against. We have a finite financial envelope to work within, so we're challenged with that. Our relationship is very strong with Kent Community Health. I meet with them currently 3 times a week. We have agreed action plans that we've jointly developed together, that we're delivering on together. And I would say that commitment to stay in the space with us is very strong. So I'm not concerned that they will step away from this before we need them to.
Thank you for that. To the first part of my question, you did explain what you're doing to address the up to 7 years waiting list. But I guess my question was, you must know how we're doing in comparison to other places. Because I have a child with autism, and I connect with sort of parents with similar conditions, children with similar conditions in other parts. And you always hear that Medway is just not doing that well. What I'm trying to say is are we really behind the curve on this compared to other parts of the country, for, like those waiting lists, or are they indicative of how it is everywhere?
Apologies, I didn't respond to that particular bit. So we are in line with what's happening nationally. The 7-year wait in terms of ADHD, we're probably one of the higher wait lengths of waiting times, but we are not out of kilter with other parts of England. So on average, people are waiting in an adult pathway, and I'm talking about an adult pathway as opposed to children's pathway, around 4 years on average for an ADHD assessment because of the demand. There is also challenges in terms of data availability, and that's being looked at by NHS England because this isn't a pathway that's had robust data collection on it because, again, the demand came with such speed that people weren't anticipating it. So, but NHS England have a whole piece of work that they're doing around data collection, data validation, understanding the pathways across England and how they're being delivered, looking at ways to innovate and improve things as well. So we're working alongside NHS England and we'll be implementing any changes that they make recommendations around while also doing stuff at a local level to move things forward.
Thank you. Councillor Amadisha.
Thank you. My question is more to do with the table we have here for the Medway referrals. I'm keen to find out the sources of these referrals because you cannot gauge that from the information that we have here. And I know you just mentioned data collection, so I think that's something that we need to be able to tunnel down and find out where are these sources emanating from, you know, and to what degree do they come from a particular service, a particular area within Medway, not just Medway. And the second question, very quickly, is about these referrals by gender. As we maybe look forward to applying some of the learnings from this into children's services, how binary are we going with the gender classifications? As somebody who works in mental health, I can tell you when you say non-specified, there's only one case of non-specified. It is far more nuanced than that when you talk about gender. And what sort of measures are you putting in place to ensure that the actual narrative of the individuals is carried through in some of these reporting? Thank you.
Thank you. So the referral sources for the pathway are predominantly from primary care through GPs and mental health colleagues from within the mental health services. Some come from social care, but predominantly mental health and primary care. Absolutely, in terms of the data set, we know it's not as robust as we would like it to be. We don't have wider categories in terms of capturing people's self-identification or other areas of need, and we're looking to be doing that as we go forward in terms of the new pathway, having a more robust data set. So absolutely hear what you're saying, that it's not as robust as we would like it to be at this point, but it's a starting point in terms of understanding the numbers and the demand that we're trying to manage at this point in time.
No, thank you.
Councillor Gilwan.
Yeah, thank you, Chair. Members tonight are being asked whether this is a substantial variation with the proposals that you're making. And I was just interested to read in 4.3 that the Kent ONS deemed that they weren't. I don't know if it's appropriate to ask you, Marie, or even the Chair, whether we know the reasons that they gave for not deeming it a substantial variation.
So there was some debate as to whether it was or wasn't, and overall more members agreed that it wasn't a substantial variation based on the fact that we're not removing any services, we're trying to enhance them and improve people's access to the service while still recognising that the demand is more significant than the capacity that's there. The debate was around whether actually that significant demand constituted a substantial variation, and its view was that that wouldn't be the case. It was actually about the service provision and access to it. That was the primary area to focus on.
Councillor Brown.
Thank you, Maria. My questions are around money again. If you've got a demand that's 600% more than what you've funded for, irrespective of who the suppliers are, how are we going to pay, how are we going to fit that if this is to be believed and the envelope is finite? How are we going to attract the providers to bring these people into service? I mean, 31,000 people is a lot of people. And if we're only financed for a little over 2,000, I don't know if you can answer this, but how are you proposing to attract new providers, number one, and actually giving them enough money to do anything reasonable about this? I know we talk about transformation, but that usually just means automation. Thanks.
So, under right to choose, we as an ICB will have to fund the assessments, the diagnosis that people choose to have through right to choose. So those providers will be paid for activity that they will undertake. That is a substantial financial risk to the ICB, but that is the way the procurement arrangements are set up nationally. And that is why, in terms of the financial envelope, maximising the outputs for people and the outcomes for people, I'm keen that we maximise the opportunities to put as much funding as we can into the community support offer, and not just into the diagnostic pathway. It's really important that people have access to support without having to go down the assessment pathway in the first place, because it's important that we maximise people's opportunities without having to wait for assessment. But that financial burden is there to the system at the moment in terms of this particular clinical pathway and the right to choose element of it.
Finally, Councillor Wildey.
Thank you. First, I made a comment about, I think it's a substantial variation because of the changes, but I don't think it will be of benefit to declare it as such. So I will be voting that it isn't, despite what I said earlier. On the numbers, if I can go back to that, you're talking about you don't put people in a queue as in when they get in touch, but as in what you think their level of need is, which is fine, but we all know for different conditions, it's the person that shouts the loudest that sometimes gets to the front of the queue. Is there a way of measuring their need before they're actually properly assessed? Now, I hate the idea of IT, as that's been mentioned as well, but could someone fill out an IT thing on the internet to give you an idea of where they should be on the queue, that sort of thing? And IT, I do not understand, so I don't know what I'm talking about, but if you can explain how it could help or not.
Thank you. I think you described it quite well. But in terms of accessing the service, yes, that would be one of the elements that we're looking to implement, and we're testing it at the moment with a number of people currently on the wait list. It is a digital form that people would complete. It's a screening tool. That's a standardized screening tool. And that would enable us to understand people's needs in terms of risk, and also in terms of clinical presentation, and being able to then triage clinically. That's quite a common practice in health pathways. It's not unique to this pathway, so it would be about ensuring people's needs are identified at that initial stage of referral.
Thank you.
Jackie.
Thank you.
I'm having trouble too. Sorry, hi Marie. I just wanted to give members some assurance about Medway Council's involvement in this. So you'll see dotted throughout the papers reference to that. That is colleagues from our commissioning team, so from Partnership Commissioning. They work on the all-age pathways, so children and adults. Work very closely with Marie. I think I can say that they challenge Marie quite regularly around some of the discussions that take place. And some of the information in the paper is specifically around areas that they've suggested, made comment on. I understand the challenge and the concerns around self-management, but that's something that we all do as a service, as health and social care. So we very much look at what's online. That doesn't mean that it stops you going on to receive those diagnoses or actually having those conversations with GPs or professionals. But one of the things that Marie and I spoke about when we talked about the waiting list, when it first started to become aware of that 600% increase, believe you me, when Marie told me about it, I was very surprised, was around actually what can we do in the meantime? So how can we support people that we know are going to be waiting for a long time by putting in some technology? And you'll also see in the paper about having people with lived experience being involved in that. So there are a number of boards that take place. I think Marie's on every meeting and I'm on some of those. But actually for the main exec board, there are people with lived experience that are members of the board, and they really do give us some challenge and hold us to account as well. So they have been part of this. They have looked at actually by having some apps, will that be supportive of them, particularly younger people. So I just wanted to say, yes, there's definitely a challenge. It is concerning about the numbers. I don't think any one of us would say that it isn't. But this has been looked at in the round. So I just wanted to give members some assurance that when it talks about Medway Council being involved, we absolutely are.
Thank you, Jackie, and thank you, members, and thank you, Marie. I think I'm. It may not be a surprise to Councillor Wiley. I'm probably on a different page to Councillor Wiley when it comes to the SV. So I think that probably in a positive way, I'm on a different page, because I believe that it's clear that there are challenges with this contract, and hence the changes needed. And you know, obviously, we always want to be involved at an early period. Sometimes that can't happen, but we do. But for me, if it goes to plan, our patients will see a difference. So if the patients are seeing a difference in the service, then I see that as a substantial variation, because I see it as even if it's an improved service, they're going to see a difference in what's being provided. And I feel because of the challenges of the waiting list and the challenges of the aspects that many members have brought up already, we want to be on that journey with you and see the improvements and see what happens alongside. I have this discussion all the time about an SV. It's not a negative, although a lot of people see it as, it's not a negative thing. It's just about us being with you on that journey and helping in whatever way we can to make it better. But to actually see the journey and to see the improvement. You know, I know you do a sterling job. I know that, and you know your papers are great as well. But we have a 7-year waiting list, and you know there needs to be improvement. I can hear what Jackie's saying as well. There, you know, and Leanne, but there are clear challenges. So. Just what I mean, Councillor Wiley. For me, if the patient is going to hopefully see a difference, then that's a change for me in service. So you know that's where I am at that. It's down to members to agree or not. But I see it as a substantial variation, although I see it as a positive step forward for the service, hopefully, with the right to choose, etc., etc. So I suppose Terry, I'm asking for that first of all, whether I've got a seconder for the SV. Councillor Cook. Councillor Wiley?
Can I suggest if we go for an SV, it is the lightest touch SV, not the most, but yes, I recommend that it's not an SV. But
we can go to a vote. I mean, I've said
Yeah.
it's about positive touch. It's not about heavy-handed touches. It's about the positive touch around making sure we get the response back and we know what's going on with the service. So I can put it to Marie. Do you want to come back?
Well, I was just going to suggest at HOSC, the suggestion from Kent County Council members was that I come back within the next 12 months with an update, hence why they were in agreement that it wasn't a substantial variation, but that they were cited on and part of the conversation going forward. So that might allow you for that, to give you that opportunity to think about it.
I mean, with all due, Marie, HOSC always take a very different view to us, and they normally come around to the same view to us when it's too late. That's happened in plenty of other contracts. So, but we are very different in our areas. So, but it's helpful, and I did watch that debate at HOSC as well. So I've got a seconder for the SV, and we'll put it to a vote then. Those for the SV? And those against? Okay, so it's carried for an SV. Okay, thank you, Marie. Vice Chair.
I move that the committee, A, note the update from the Kent and Medway Partnership for Neurodiversity as set out in this report and at the substantial variation questionnaire attached at Appendix 1 to this report, and B, agrees that the proposals do constitute a substantial variation or development in the provision of health services in Medway.
Is that seconded? Agreed, members? Agreed. And Marie, we will be in touch. I mean, it will be, as Councillor Wilder said, it's the lightest touch SV, but we want to be on this journey with you. Okay. But Terry and our team will be in touch. But thank you very much for your time. Thank you. Mortality rates we've now got. Can I ask? Just in case we don't know who you are, Jane, just in case.
Just testing. And can I check that means you can hear me now? Very good.
Okay, as before, thank you very much for waiting. Obviously, members have read the papers, but if you want to just give a highlight, that'd be great.
Thank you. So I'll give the highlights and I'm very happy to take questions. So thank you for the opportunity to come and speak about our mortality rates at the hospital. I'm Alison Davis, I'm the Chief Medical Officer. So just what I want to describe is the context of our mortality rates at the hospital, what the improvements we have made to date and what we are doing now and what we're going to do next. First, I want to assure all of the members of HASC that we take our mortality indices incredibly seriously, and we're working to improve them. For both our SHIMI and HMSR, which are the two national metrics of mortality, the indices are outside the expected range. And for those who have been involved with Medway for longer than I have, I know that this is something that has been an issue in the past, and there have been times when the mortality indices have been within the expected range and outside the expected range equally. So what we're doing at the hospital is working to find sustainable improvements that will ensure that we provide the best care and treatment for our patients, but also I would want to emphasise that this is a whole healthcare system response. In terms of the mortality indices, I suppose the best way of describing them is that they're a smoke signal. When they go outside the expected range, it is for us to then determine where there may be issues and what we need to do next. So what I've done in the paper is I've shown a diagram, if you like, a methodology for how to investigate mortality indices, which is the pyramid you can see. So I thought I'd just highlight a few points from the paper in relation to that. So when we started to look at our mortality indices, which had shown an improvement and in recent months have increased again to be outside the expected range, we first of all looked at our data, and back into 2023, so last year, we did a lot of work to improve the quality of our data to ensure that we are looking at the correct areas for improvement, to the extent that we are now better than the national median for our depth of coding, which is one of the measures of data quality. A lot of the work that we did last year was around ensuring accurate documentation and then the accurate documentation feeding through to the data sets. The next segment of the pyramid in terms of investigating mortality indices is to look at patient case mix. We know that we have a complex case mix of our patients that present to us at the hospital. It's a reflection of the fact of we work with and have the privilege to look after the residents of Medway, but many of whom live in deprived communities, and it is well known that deprivation is associated with poor health. Equally, we have low numbers of GPs per head of population and amongst the lowest in the country. And the third point I want to make is we have significant numbers of patients who are frail in our over 75-year age group. In terms of looking at care and resources and the processes we have in place, in terms of one of the real positives, and I hope that many of you will have seen, that we have the best ambulance handovers in the country. That has been a huge amount of work across the whole system, and I'm grateful for colleagues who've helped and supported that. But the knock-on of that is we therefore have a very crowded emergency department. We're working hard to improve that, and our 4-hour performance in our emergency department has shown a significant improvement. However, we all recognise, and I was in ED just before I came here this evening, that we have many patients who wait far too long in our emergency department. And as Lord Darcy described in his report, long wait times in ED are associated with increasing mortality. So to that end, we are focusing on how we can improve the flow through the hospital, both in terms of admission, patient having alternatives to admission, and equally patients being discharged in a timely way. And second positive I want to highlight is that we've worked over the last 18 months to reduce the numbers of avoidable cardiac and peri-arrest calls, otherwise known as 222 calls in the hospital. To that end, we've shown a significant and sustained improvement, and we're proud to be winners of the South East Parliamentary Awards in 2023, and also nominated as part of the HSJ Health Service Journal Awards for patient safety last year. In terms of how we now move forward and continue to learn when our patients sadly pass away in hospital, there's a very clear methodology which we are improving and developing and embedding. I've detailed structured judgment reviews, which is the process we use in working with medical examiners who are independent of but work with us when we review deaths. I know there was a question relating to safeguarding and how our colleagues in safeguarding work with us looking at structured judgment reviews, and they are integral to that process so that we can ensure that any of our most vulnerable patients are reviewed in an appropriate way. In terms of next steps, we're going to continue to work using our patient-first methodology, which is our quality improvement methodology in the Trust, to look at patients who are admitted along our emergency pathways, which is where we are, the outlier status is most obvious. There are particular disease groups, I've mentioned briefly respiratory disease here, but there are particular disease groups and
conditions that we will review in detail. We will continue to embed the learning from deaths process, which I've described, and particular focus around our end-of-life care pathways, ensuring that our patients who require palliative or end-of-life care are treated and cared for with the dignity and respect that is appropriate. Underpinning all of this and going back to the methodology described in the paper is continuing work to ensure the accuracy and quality of our data. I'll just finish by saying that, just to emphasize, as a hospital, we take this incredibly seriously. We want to be completely open and transparent about the work that we are doing. But from my perspective as a CMO, whilst we work to do everything we possibly can within the hospital, this is a wider problem and a reflection of what goes on beyond the hospital. So both within the community, public health and social care, which I would humbly suggest you're better at looking after patients from a social care perspective than we are in the hospital. So I'll pause there. I'm very happy to take questions.
Thank you, Alison. Councillor Medici.
Thank you, and I totally agree in terms of the data collection side of things is very, very important. There's a bullet point you mentioned here about the treatment escalation plans, those TEP forms. I just want to know, how far are you in terms of the integration of those TEP forms into the actual hospital EPR system, so you don't have two versions of the truth afoot?
Thank you for that question. So we've made significant improvement through our avoidable cardiac arrest level 2 work to ensure that for the TEP forms of ensuring that patients, it's clear at what is their ceiling of care. So we've worked to improve that and ensure that all patients have that completed when they arrive in hospital, and that is reviewed as appropriate. And we are now, the final piece of work that we're doing is to have that recorded electronically, and then it feeds into our electronic patient record so that it's visible to everyone. So that's an ongoing piece of work, but that is part and parcel of something that every patient has.
Yeah, any dates in terms of when that will be fully integrated into the system?
In terms of patient care, it's fully integrated now. In terms of the electronic piece, probably a couple of more months.
Thank you.
Councillor Wilding.
Thank you. My understanding is, sorry, on 4.6, the death rate, not really a good phrase, is 113. My understanding is that the standard is 100, and that's not actual deaths, that is the way you measure them, statistically. But does that mean it was 13% higher than the expectation, because it is 113? And my other question is, because your rate of people dying was so high, has that made you risk adverse? Would you not perform operations that you may have otherwise, etc., etc.? Now, I know we've had this conversation before, but I think we should have that publicly as well. So
yeah, no, and thank you, Councillor Wilding. It's nice to see you again.
Yes.
The short answer to your first question around 13% is no. But the longer answer is that the statistical methodology that is used is 100 is the benchmark, and then there's a funnel plot. And from that, you can see whether or not you're outside the expected range, but it doesn't relate to percentages per se. It's absolute numbers, and it's a method, way the methodology is. And then the second point about being risk averse, absolutely not. We work to ensure that every patient has the treatment and care that they provide, that they require. That's what patient first is. It's what I get out of bed every day in the morning to provide for the patients at Medway and to support all our staff. So absolutely not. And I think one of the points perhaps that I haven't drawn out in this paper is that we benchmark all our services against national data. We work collaboratively across the system in order to provide the care for across Kent and Medway ICS, but we benchmark nationally. So whenever we're looking at any treatment that anybody may require, it's at that level that we work to, using all the best practice that's available.
Can I come back? If it's not 13%, can you give us an indication in percentages what it would be above the base rate, the norm, however that could be provided?
I'm afraid that the methodology doesn't work like that, so I can't give you a number in that. What it does show and what is important is that when you move outside the expected range, you then start to do the work to understand why that might be the case.
Okay, thank you.
Thank you for the question.
So Cook.
Thank you. There's so much to learn in learning on this committee, and really grateful for everything that you're sharing with us. And one of the first things that I started to understand after I had the privilege of being elected a councillor was the link between people coming into hospital and emergency care, people being released from hospital, and there being the right social care to surround them. And that's really explained in 4.18, and that really jumped out at me as something significant. Is there more data around how many deaths are as a result of that system not working? Because it feels quite important for this committee around that being a real indicator about the wider social care and the impact that's having on that kind of in and out interplay between hospital care and wider social care. Do we have any breakdown of the impact of that specifically? Thank you.
Not from this data set and the mortality indices per se, but more broadly, the Royal College of Emergency Medicine and the Getting It Right First Time programme, both of, and the Royal College of Emergency Medicine report is quoted in Lord Darcy's investigation of the NHS, and within that it's recognised that, as I described, delays in hospital care because patient ending up waiting for a long time in ED has a demonstrable effect on mortality. And when you're within the hospital, it's that whole flow, and the hospital, we're just one part of an integral health and care partnership, and therefore it's everything that we can do to ensure the patients only come to hospital when they absolutely need to, and go home, go home as soon as possible. But you see in the paper, I quote, that we, at any one time, from the data sets we use, we're 40 to 100 beds short, and at any one time we have 100 to 140 patients who no longer require to be in hospital. And as one patient I spoke to, it was last winter, said to me, "Alison, I just want to go home, please." And I thought, well, actually, I just want you to go home too. So, in the nicest possible way. So it is absolutely, it's that whole piece. And I think that's why, from a HASC perspective, us working together, Jane wants to come in here, but actually, what is it that we can do differently for our patients, population, our residents of Medway, because this has been something I've been here, as I explained to Councillor MacDonald, a relatively short period of time. I've been here 2.5 years. There are many of you who've been here for a very long time in Medway, and you've seen all of this play out before. And what that suggests to me is carrying on doing more of the same isn't going to work, and we need to do something different for our residents and our patients. Jane, if you want to... Jane.
Can I just add a little bit to that, really, because there's a number of things. It is quite complex when we're looking at this type of thing, but I think I'm really clear. I think our organisation is very clear that what's within our gift we have to deal with. So as patients come into us, we need to make sure that we've got our flow working as much as possible, notwithstanding the fact that we are about 100 beds short at any point in time. Generally, we haven't got enough capacity. I think the important bit is about the work that we are trying to do across the system. So there are things, where we need to look at now about actually patients not coming to us. So you will hear about things around SPOA, which is about the single point of access, which we're working with CCAM. That is so important because actually that's about CCAM talking with professionals and clinicians about the right place to bring patients. And we're not always the right place. So that's really important about doing some of that pre-admission work, if you like, or hospital avoidance. I think the other piece that's really important is that certainly as senior leaders in the Health and Care Partnership, we need to make sure we've got the right provision outside of hospital, making sure that we're not holding on to people too long at any point in time. And I think there is a real opportunity for us to learn from others across Kent and Medway and across regionally about what we can do differently. And I think that's really important because at the moment, it's not anyone's fault that we are blocked at any point in time. It's not about the fact we have no criteria to reside patients, but it's also about it's our responsibility to make sure that we try and get those pathways right. So there's a lot of work internally being done with our clinicians. We've had 2 away days just recently, whereby we are looking at changing the models within our own gift about what we can do, but it has to link up. And certainly Leanne and I talk on a regular basis now about what we can do differently. And it will, also look at the community services that we've got and are we using them in the right way.
Thank you. Because you mentioned ED and people being kept there can be detrimental, I'd just like to say my mother-in-law was in the ED for much too long from what everybody would wish, but she had wonderful care. She was monitored, everything you could wish for as, just someone observing with no great knowledge. It seemed you carried out your work as best you could and, I'm grateful for that. So, yes, it may go wrong at times, but from what I saw, your hospital does its best. So, thank you.
Councillor Brown.
Thank you, Alison. Thank you, Jane. Firstly, I'd like to congratulate you on the improvements that you've made around the ambulance times. We had the privilege of having a look at what CCAM are doing to prevent people presenting at hospital. Do you think that can give you some more? In one way, it's a double-edged sword because the people that you get are going to be more acute, possibly. And I'm just wondering, have you done any analysis on any changes in the presentation that you're seeing? And that could be not necessarily from the preventative side, but actually from the causal side of why they're coming. I don't know if you've done anything on that. I know we're talking about mortality here, but I'm trying to find out about the strands.
Yeah, no, and I understand that it's a really helpful question. I think the view I would take is we get the right patients. Because if we have patients who can be better cared for in the community and don't need to come to hospital, if they come to hospital, then they get sort of mixed up, if you like, with the patients who really need our care. So I'd rather have that distillation of complex patients that really need us, and so we can get to them quicker, than having patients who have the trauma of coming into hospital by ambulance and in fact could have been cared for in a better way somewhere else with appropriate healthcare clinicians and social care.
Can I just add, when we did the pilot, we did it for 2 or 3 months it was, and we see around about 115, 120 ambulances a day. That is a lot. It's one of the busiest in Kent, actually. It's busy for the size of the hospital we are. But actually, as we started to use the SPOA, we were seeing that they were diverting about 10 to 15 ambulances to a different place, but the right place. Now, 10 to 15 people is a lot to us. And actually that stops people being in places within the ED that are not always in a cubicle. As certainly some of the councillors know, we've done a lot of work to not have corridor care, and we came out of the corridor in April, but we still have undesignated areas within ED that we have still got to work on. So, you know, it's made some difference, and I think it has made a big difference to the environment for the patients when they come into ED, but also it's made a big difference to the staff.
Thank you, thank you both. I think I just want to bring it back to mortality again, because, you know, Councillor Ridley was saying, I think it's clear, and you would agree, you're quite up there on the table. You know, we're not talking about, we're talking within the top 10, we're not talking further down. And there are many aspects, I know, that cause that, and you know, and I know you're doing some sterling work up there, but we have to bring it back to some of the stuff in the report. And, you know, when I read in the report where you say about improving palliative care options and missed opportunities, that's a worry for me. Because it's all, you know, what are we missing when it comes to putting out, you know, to talk about our palliative care options with our patients. And then when you say further down, I mean, Councillor Hamadishi mentioned about the correct completion of the treatment escalation plans and DNR, especially for people with learning disabilities. Why are we still missing that? You know, we've had this conversation, Jane, for a long time. Why are aspects of people with learning disabilities being missed when it comes to that treatment escalation and DNR? I mean, I've got others, but do you want to come back on them? Because, you know, to me, we should never miss opportunities about improving palliative care options, and also we should never be. And I think, Jane, you remember before you come, we've had it before, many members will remember, where one of the biggest things from CQC in the past was about the correct completion of paperwork and making sure people weren't missed out, including those individuals from you know, like learning disabilities, etc. And we're back there again. I don't quite get it.
So the short answer is yes, I completely agree. In terms of the work that we have done and the work that I've done whilst I've been in Medway, in terms of both palliative care and DNA CPR, those were the areas that are highlighted through the avoidable 222 work. And we have shown a consistent and sustained improvement over the last 18 months, to the extent that I'm now confident that we can translate that into business as usual. I think whenever you do quality improvement work, you've got to, when you start, you've got to work out what the end point is, and the end point has got to be resilience and sustainability. And I think when the changes had been put in place previously, what I suspect may have happened is that then the how do we keep this going conversation perhaps wasn't as robust as it needed to be. There wasn't a home for where these areas were going to be monitored, because I think, as we all know, if you monitor something, the likelihood of it being maintained is significantly greater. So for the palliative care tech, we will continue to monitor that. Similarly, you know, our patients who making sure they have the right, they're very clear, if you like, homes for that work, for that to be monitored. And I think that perhaps the other point is the patient-first quality improvement methodology we use has what we call watch metrics. So we work very hard to drive things and drive improvements, but then once we get to the end, they don't just, that's the end of that. They then translate into watch metrics. So we're, at an executive level, we'll be able to watch the improvements and ensure that they are sustained and step in quickly if we notice things going in a direction which is not as we would wish.
So I totally get that. So I you know, and I suppose I'm coming from a simplified approach. It's more detailed than that inside where you are, I suppose. But the impacts of that, then missed opportunities, lead to where we are today. I mean, you know, you look at that. I mean, another comment in there was around Medway has the highest percentage for mortality for the over 75s with frailty conditions. You know, it's not a good optic. And I know, Jane, I know that the hospital has improved dramatically, right? And I would, you know, we would want all of our residents to know it's a safe place which is improving and to build confidence in our community to use it. But when you've got families that have got individuals over 75 years old, would they want to be sending them to the hospital? And they're the elements I think we need to be looking at around, you know, they're not, and you know, I'm going to use the word, it's not the right word, they're not quick wins, I know, because there's all them other facets that them other building blocks that create those problems. But it's quite sad seeing these issues, because I remember seeing these in 2015. I remember reading back on reports in 2011, 2012, 2013, where it was the same issues around mortality. Mortality is not just something that's crept up on Medway. It's been an ongoing issue, and that's why I said to you on our meeting beforehand, oh no, why are we back here again? Because the other aspects, the ambulance and the service, the waiting times, has improved so much. Yet there's obviously, and we've got to mention the issue, there's obviously still an issue here with regards to the reporting. And you know, I see you've got here monitoring. I was going to ask you how many deep dives are you doing now, and have you now got the clinical learning lead for deafs in place? I mean, what a thing. What a thing to have to, you know, we have to have a clinical learning lead for deafs in Medway Hospital. I mean, it's probably a really important role, but is that in place?
So just going from the last question first, if I may. So we have a clinical lead for, that's an important point, because learning from death is a crucial part of the NHS. So for me, that investment was really important. I also have a medical director for quality and safety, who is the person who leads for me within the CMO team, looking at mortality. So I see those as positives and things we absolutely have to do. I think from the perspective of frailty, the reason for highlighting that is that it's about, and this is the point that Jane was making, what else can we do? Because very sadly, patients who are frail, not all elderly patients are frail. It's, you know, a very clear clinical diagnosis. But sadly, frail patients have a limited life expectancy. What is it that we can do to ensure that those patients don't come to hospital unless they have to, and when they are with us for the shortest period of time? So it is an area of work and focus that we need to continue with. One of my reflections, and I've gone back into previous reports, I haven't found the 2011 one yet, but I shall dig around and find it, is just how we tackle mortality altogether. Because this isn't something, we, as Jane has said, we have a commitment, obligation to ensure that we do the very best we can in terms of treatment and care. In order to do that, we need all partners to be on that journey with us. And I think some of the work that we want to do out with community partners around frailty, which is already being done in other parts of Kent and Medway, to be honest, and also being done across England. I think there's a significant opportunity for us to change clinical pathways, and that's where we need to go next.
So just to be clear, and I know you're not throwing the blame around, I do know, but I'm going to ask the question because I will want to ask. So are we definitely saying that the mortality rate issue is a whole system approach failure, not just with the hospital? Mentioning social care quite often tonight, we mention others. I want to know, are you saying that your mortality rate, the failure of your mortality rate, is the whole system approach, not just within the clinical?
So I think we're not blaming everyone else. This is about making sure from this report that we are doing everything that we need to do internally. And I think that is really important. You talked about the fact about sustainability. And I think some of this is about the fact that actions were put in place that were then reduced. And that may have been a change in pathways, but it definitely was a change in making sure that the data was collected appropriately and recorded, etc. Now, that did slip. I'm not saying it's just data, because what we can see is that we have put actions in place and it has improved around that again. But we have to make sure, using our methodology, that it remains sustainable so that we don't keep getting this up and down, business going on. But there's definitely for us within the organisation to make sure that any elements that are coming through when we look at our learning from deafs is that if it is related to any of the pathways that we have to look at it as a whole. We can't just look at it in one isolation piece. So it's important that we do that. So it's not about putting blame anywhere. It's about making sure, A, we are absolutely clear of the things that we need to do and within our gift to solve. But also, if there's something along the pathway, often it is about, where we're talking about patients coming in to be admitted, do they need to come and be admitted? If they are end of life, for example, because there may not be options for them to have, they are coming into our ED department and then being admitted. So there are things that I think that the solutions are better if we look at it as a system.
And I totally agree, Jane. It's not about putting the blame on, it's about lowering the mortality rate.
Absolutely.
So, I suppose what I'm saying is there lessons to learn? Is there lessons to be learned from the whole structure and family around the hospital, and not only the hospital? Because otherwise, I fear we'll be here in 10 years' time with your mortality rate still not through the great work of what you're doing, but we'll still be in the same position. So maybe something to take away and learn from about, the posts you've put in place now, which are really helpful, and you do need those posts, sharing that data, sharing that intelligence to see how the system can help.
Yeah, and I think you're right. I think it is about us being open and sharing so that we can learn.
Because what we want to do is make sure there's confidence in residents using our hospital. Okay. Vice Chair.
I move that the committee notes the report.
Seconded, Councillor Brown. Agreed, members? Agreed. Thank you so much, Alison. Thank you, Jane.
Thank you.
Thank you. Rachel and our stroke provision, and then we're going to have a break straight after that when we put the people on. Thank you. Have you got your name badges up there? I don't want to start calling you Jane again. Let's have a look. There we go. Thank you, Peter. Thank you. Okay, so as before, who's introducing the paper? Over to you, Peter. Just the highlights, obviously.
Good evening, and thank you for inviting us back to talk to you about the TIA service within Kent and Medway. I think I would start off by saying that when I was here last, I was reasonably, if not very confident, that by this stage, I would be able to report back to you that the residents of Medway and Swale were having their, even though the TIA expertise sat in both Downth Valley and Maidstone Hospital, that the residents of Medway would rarely need to leave Medway in order to get the service that they needed. As you will see from the paper, which I won't go into in any detail because I'll take it as read, that we have had some, first of all, digital issues in waiting for MFT to implement their electronic patient record, but that has now reached a stage where we are able to certainly provide some safety elements of the TIA pathway for the residents of Medway. However, we are still struggling with getting a pharmacy service up and going digitally and at distance. And because of that, I cannot say to you today, unfortunately, that I was good to my word that I would come back and report that everything was provided for the people of Medway from Medway. I can go into more details and obviously happy to take any questions.
Thank you, Peter. Members? Councillor Wiley?
Thank you. You say because of the pharmacy, I think that's always been a weakness at our hospital, so, well, at MFT. So I would have thought that would have been understood from the beginning and would have been one of the first areas you would have been working on to sort out. I mean, I have lots of comments that aren't really helpful, going back to the old stroke review, you know, taking over 10 years, nearly 14 years to come to fruition from when it first started. We started with 7 consultants. I don't know how many within Kent are now working on strokes, but all of those historical issues, if you like, and taking away the best at the time provision for strokes from MFT. I know TIA is slightly different, but you know, stroke care was provided very well from MFT for a number of years until the stroke review took it away. And now you're still telling us that we are struggling to get the service that other areas get. I find that more than annoying. And to rub salt in the wound, you talk about Bexley in these papers, which always had a HASU in Orpington, if my memory serves me right. And I also remember I wasn't the only person that mentioned if you lived in Bexley and you was fit and healthy, you could probably walk to a HASU quicker, a hyperacute stroke unit, quicker than a Medway resident could get an ambulance to either Maidstone or Darren Valley, considering that the ambulance times were not good at those times. So I'm pleased you're admitting that the service isn't as good as you wanted it to be. But I do think Medway and Medway residents have been very, very poorly treated with the whole process. This report does not have a dot map from where every stroke patient goes to the different hospitals, because again, that always showed a lot of patients come from Gillingham or Chatham, the biggest concentrations. So I still feel we need a stroke unit within Medway Hospital, and we are, well, even struggling for the TIA service. So very disappointed. Thank you.
Peter, did you want to respond?
Well, yeah, I'm delighted to respond because I think I started my consultant life as a stroke consultant in 2016. So I have been on the process virtually from the beginning. And I've yet to meet another clinician that hasn't also been as frustrated as perhaps your frustration as well, but for very different reasons. Today we are here to talk about TIA. And I'm not sure how helpful it will be for me to respond to you on something that has been all of the way up to the Secretary of State for Health. And in fact, the delay, the biggest delay is because of the judicial reviews that were insisted upon by, well, I don't know who. It's also interesting to look at the tables provided in Appendix 1, where it's quite clear that none of the hospitals in Kent and Medway, including Medway, provided an adequate stroke service. And it was about the time, probably it was 2018, around there, that the evidence came out and was quite resoundingly clear that patients with stroke got better care in a stroke unit that saw more than, I think it was 450 people. And that effect, the bigger the stroke unit, the better care you got, up to a ceiling of about 900, 1,000. And I'm slightly inaccurate with my numbers, and apologies for that, but that's the ballpark. And it's good to see, I think, that whereas previous to the consultation, we had so much trouble finding stroke consultants wanting to work in Kent and Medway, stroke nurses. Nobody wanted to touch us because of the poor care that we all gave. That's Maidstone, Tunbridge Wells, down in Margate, William Harvey, Darren Valley. And when I look at the table in Appendix 1 that shows very poor performance until we made the change, and now see very good performance across the board, which includes Medway patients, I've got to say that I hold a different view to you, sir, that I think it was a good thing that we did what we did. Now, whether or not Medway should have been chosen as one of the hyperacute stroke units during the consultation is another question. And I do remember the time when that decision was made. I remember the journey times. I remember the argument that because of cardiovascular and cerebrovascular disease within the Medway area being higher than it was, that it was certainly an argument to have the hyperacute stroke unit at MFT. The decision wasn't my decision, of course, but a decision was made that that wasn't the case. And when I hear and I hesitate to link it back to the previous item, but when I hear the problems that MFT has in the number of beds that they are short, it makes me wonder whether or not it was, and then hearing your question, I wonder whether that's relevant in your question as well. So to conclude, it was all consultations, all services going away from any hospital always leaves a very bad taste in people's mouths. If we're putting patients first, then I would just refer myself back to that table to see that actually things seems to have improved. We absolutely have got huge numbers of consultants compared to what we had before, and nurses, a 7-day service, and a TIA service, actually, I think, to be proud of. I do understand that people of Medway have to travel either to Maidstone Hospital, I don't know how many miles that is from Medway to Maidstone, or to Darren Valley. Just like people who kind of live in Margate now have to travel to Canterbury. And all I would say on the patient experience point of view is when we generally ask patients what they want an excellent service and they are prepared to travel for it. I think I'll stop there. I could go on for ages, but thank you for the question and allowing me to answer it.
I don't really want to revisit the...
No.
The only thing I would say, Peter, is obviously, and I know you know this, I'm going to say it anyway, obviously, at the time the committee felt the way they did, that's why we went through judicial review, and that's why we went through that process. I think you touched on that. Obviously, each area would always love a service within their own area, and I agree with what you're saying. I think that boat sailed. The main priority, I feel, and I think, David, you was going to say it, sorry, I think that the main issue... I suppose the main priority is to make sure we've got a safe service available for our residents. And, from the report I've read, we seem to have that in place. Obviously, we've got a gap with the pharmacy. Hopefully, that's going to be resolved. Is that correct?
Oh, yeah. I don't want to do what I did last time.
I'm not asking you to commit, but that is the hope, is that we will...
Absolutely. So there is a system called EMIS, which is something that allows the GPs use it at the moment. We have to introduce it, in my view. But it's not a short-term
No
thing.
problem. But just because that is in place doesn't mean we're still not having a safe. We've still got the safe system and the safe service in place.
It is, you know, end-to-end services with minimal handoffs. With, you know, I have personally tried to navigate myself through NHS services, and I know what I'm talking about-ish, and I find it very difficult. So I think it is better that we keep it simple, but please be assured that we are working on all of the other things on that list, and some of them have come to fruition. The last one on the list will be pharmacy, and that's when we intend to move it back as we originally proposed.
So do you want to come in just quickly?
If I can, yes, the service is much better than it used to be. The medical improvements are wonderful. I do think if you ask somebody that survived having a stroke, what sort of care, simply to be there still, they are going to say it was a good, they're happy with the care they received. Sorry, and the judicial review took 1 year out of the 10 plus years, but as you say, it's not worth having old arguments. Yeah, even though it concerns me, someone going down Bluebell Hill when it's congested, there's been a crash, etc. But it will be good to have the TIA service back at Medway, and I'll still, again, it was left until Medway nurses was down to, I believe, 1 before it was actually had to be moved. Whereas I think we would all agree it would have been better if it had been noticed earlier that they were losing nurses from, again, by memory, start with 6. In any other business, you wouldn't leave it until you get down to 1 before you then close it. But again, even that's historical. But thank you.
I can reassure you, I don't mind saying that I've actually done the run in the ambulance to Maidstone to that unit, and I was there in no time at all in rush hour. So I was quite surprised myself. Thankfully for me, it was a good thing. But you know, I was at Maidstone in no time, and I was quite surprised at how quick during. I think it was around 5:30 in the evening, and it was a very, very good. Very rarely I'll compliment, but I will. It was a very good service when I got there. So I will say, if I was to get the same, if others are getting the same service as me, then we should be very happy with that. But I do take on board what you're saying. Of course, we would still like our own service. Vice Chair.
I move that the committee notes the report.
Seconded? Seconded. Is that agreed, members? Thank you so much, Rach. Thank you, Peter. Thank you. Can I ask the ICB colleagues to come up and grab your name badges? We're just going to have a very, very few minutes break, just a quick comfort break. much, everybody. Thank you very much. Who's back on? Sorry to keep you waiting. Welcome. Shall I just get you to all introduce yourself for those members that may not need? We have got a couple of new members. But obviously, as per, I know you're going to do a presentation, as per before, keep it, we've read the reports, we've read the very extensive pack. And it's the questions, I think, are key tonight more than, and I know you're desperate to hear the questions as well. So, who's leading this? Kate, are you leading it?
Perfect, thank you. You've obviously worked these before. So I'm Kate Langford. I'm the Chief Medical Officer of the ICB, and I'll just go along the line and just ask everybody to introduce themselves. So Mark, can I start with you?
Thank you very much. I'm Mark Atkinson, Director of System-Wide Commissioning and Operational Planning at the ICB.
Good evening, Natalie Davies. I'm Chief of Staff at the ICB.
Sorry, clumsy. I'm Ivor Duffy. I'm the Chief Finance Officer of the ICB.
Good evening, everybody. My name is Mike Gilbert. I'm the Director of Governance at the ICB.
Good evening, everybody. Pleasure to be here. I'm Paul Lumsden. I'm the Chief Nurse for the ICB.
So thank you. We've sent in a short presentation to help with our discussions tonight. I know you have seen it already, so we'll just go through it very, very briefly. I'm just going to introduce it, then I will pass to Mark to give us the history and current status. Natalie will talk to us about the engagement and communication that we've done already. We have the possibility to give some financial figures which would need to be in a part 2 discussion, and we're all here to take your questions and hopefully give you some assurance on the process. So just to frame this then as the introduction and overview, the procurement of adults and children's physical community healthcare services is on an as-is basis, so we are re-procuring the services that we have in place currently. There is a critical need to ensure that we modernise and innovate and join up care focused around people in the community. And so during the lifetime of the contract, we will be expecting that services will evolve and change, and not least because we now have really clear direction from the Secretary of State on what he wants to see. And he wants to see services moving from hospitals to communities. He wants to see us making services change from analogue to digital, and he wants to see us focus much more on prevention than on cure. And I think that picks up many of the strands of the presentations that we've heard previously this evening. So currently we have paused the procurement to allow for us to come and see you today and have a further conversation. And the presentation is in light both in the requests from HASC previously and the letter from the 10th of October that we received from Councillor Murray and Richard Hicks. So we're going to give you, hopefully give you a summary of where we are today. So if I can now pass on to Mark. Thank you.
Thank you very much, Kate. So I've been to HASC on a number of occasions, I think over the last 12 months, and the current contract for community services has just less than 12 months left to run. There is a legal requirement for us to re-procure and deliver a new contract for the patients and clients of Medway, and so we're working obviously to deliver that. We expect improvements over the life of the contract, as Kate said, and those improvements are in light of the Darcy report, and as Kate said, we're expecting there to be a greater emphasis on community services, delivery of a greater cohort of care in the community, and what Wes Streeting describes as that left shift. As Kate's mentioned, so this is in Kent and Medway, it's 6 lots. For Medway residents, it's an adult's lot and a children's lots. And as we've already mentioned, what we've been doing over the last couple of months is working with the current incumbent providers to look at the service specifications. A number of those haven't been updated for a few years, so we've been working with those. So we're now in a place where we've got the as-is service specifications, 25 for adults and 23 for children. And alongside those service specifications, we've got a revised set of key performance indicators or outcome measures. We've reflected on best practice and sort of national guidance from our NHSE colleagues. So we feel that we're in a good place with the service specifications and the KPIs and outcomes. And as Kate's mentioned, they are as is. And what we're hoping to do is work with the providers to deliver that change, those improvements, the quality improvements over the life cycle of that contract. So working towards an eight-year span so that we can deliver high quality, effective care for the patients and clients of Medway. And I think this is a real opportunity for us. I know I've been here on a number of occasions and I've said that to you. But with all of the information that we've had around the Darcy report, I feel we need to do something now rather than waiting for a longer period of time. So I'm now going to hand over to Ivor.
Ivor can talk on comms and engagement, but I'm going to take it tonight. So hopefully, as you say, you've had a chance to read the pack. In there, we've really detailed the communications and engagement we've done now. But I really want to emphasise that what's been done up till now is absolutely the first stage of engagement rather than consultation. And you can see what we've done there in terms of bringing together everything that people have already told us, looking at the information that we have, seeking out the views of partners, service providers, members of public, staff critically as well, to pull that together and see where we are now. And you can see that start of those things that we've done as part of the surveys. What we're going to be going on to do, and this is absolutely something that we want to bring this committee along on the journey with, also the staff, also the patients, also the communities in Medway, is around making sure that we're developing those services that are absolutely fit for the future, that they are what the population want, what the population need, and are designed absolutely with those people. And critically, that also has to be designed with the provider that will be winning the contracts for Medway, so that we can design that together. We can properly consult with yourselves, with the public, and with other key stakeholders to make sure that those services can absolutely be developed and are fit for purpose. Now I am handing over to Ivor.
Have to learn how to do that. So picking up the finances, we're happy to have the more detailed conversations of finances in part 2 because we've provided some information about the Medway and Swell finances. The key thing for us is to level up services. There is a bit for us about ensuring that we are investing more in community, as a number have mentioned, the Darcy review and the left shift. This is the direction we're going, and for us it's about bringing those services up across the patch. The envelope is fixed for 5 years, and we'll be picking up the CUF, it's a very exciting NHS term, around the inflationary levels that we're putting into all of the contracts. And we are proceeding the procurement along the current PSR regime along a competitive process. But again, happy to take further questions later on in part 2.
Thanks very much, Ivor. So just to conclude then, we are looking to procure as is for the services that we currently have using the provider selection regime. As Natalie's described, we've already been doing extensive engagement to support the start of this process. We are really clear that during the lifetime of the contract, we will wish to further develop services, and we will carry out all the required further engagement as we get to that stage. And of course, we would consult with yourselves at the point at which we have a proposed change to services to bring you. We would want to develop that with you. We're not at that stage yet, but we're really clear that that will happen during the lifetime of this contract. So that's probably a good place for us to stop, and for us then to take your questions. Thank you.
Thanks, Kate. Can I just remind members that there is an exempt appendices with this report. Can we try and refrain from straying into that detail while we're in open session? Otherwise, we'll have to close the session. So unless there's a real need, can we stay away from that? Otherwise, we'd have to close the session and remove any public or press from the room. If you need to refer to it in the specifics, then indicate, and then I would go into a closed session if needed. But if we can avoid it, that would be really helpful. We'll go over to questions. Can I just remind our ICB colleagues again? I know I've seen in the report again, it seems to be a standard response, and I suppose it's just a reminder from me that, you know, this committee has put this into a substantial variation. And I know, and rightly so, you keep pushing back on that in your paper, but I just want to remind again that we have put this into an SV, this community procurement, including the children's services element that come to us at a very late stage. In that being said, we want to move forward in a positive way and move forward in a productive way. So I'm going to open the floor for questions. Members. Councillor Hine.
Thank you, Chair. And thank you, Ms Langford, and all of your colleagues this evening for being here. And it's very important that we take the time to scrutinise this matter as effectively as possible tonight. Thank you for all the information that you've shared with the committee as well. My first question is just around how the ICB plan to mitigate any potential disruption to services as we move from one provider to another. I think everyone that currently benefits from the community services will want to see a continuous, or like what's the term? Yeah, they want to see continuity, exactly. Mm-hmm. So that's one of my questions. The second one is around how the ICB is working with providers to cover the wide amount of vacancies that we're seeing in large parts of the workforce at the moment, with occupational therapists or speech language therapists. I'd be interested to see what you say on that. And I've just got some questions on autism assessments as well, which I'll come back to if I can after that. Thank you.
Thank you very much. Do you want to answer the one about the transitions?
Yes, so in the procurement timeframe, we've built in 6 months transition period, so from contract award to mobilisation. A bit of that was from learning from previous experiences, so we've got a robust length of time to enable that smooth transition, including all the GP transfer and etc. for those providers. So we're confident that that's in place in our timeframe.
Thank you. I wonder if you could just say a little bit more about your question on the staffing levels. Is that the as-is staffing levels now?
Yes, that's correct.
Okay, so in terms of how we work with our providers across the system, we have a supportive role in the ICB. We have, for example, today was World AHP Day. Or yesterday, actually, you mentioned a few of the staff groups in that. So we provide supportive development to bring together those staff groups in networks across the ICB. So we see that as a very important way of helping them where some services are fragile, help each other, because many of those areas, and some you mentioned specifically, are nationally shortage areas. So we think that by focusing on how we network AHPs and have a chief AHP for Kent and Medway, we are raising the profile nationally of this as a place to work for those short supply specialties.
Okay.
Thank you. I think the challenge on workforce is in all services at all times. So the other role that the ICB fulfills is we pull together all the chief nurses from the providers, and I also work with the chief people officers to look at how we can move forward with the strategy for recruitment. That also means we work very closely with the university, look at the pipeline and how we can get people to come into professions and then deliver the services. It's going to be a continual challenge, but one that we'll work collectively to address.
Thank you. If I may, Chair, just one more question on autism assessments. Do you happen to know the current wait times for autism assessments?
So I think that probably relates back to Marie's paper more than this paper, so I'm afraid I don't have the detail of that and how she's gone.
Okay. Of course, we have a SEND inspection coming up later in November. So we need to have some sort of idea how we're going to address the current wait times with autism assessments. But perhaps that was a question for Marie, but yeah, I'll come back to that. Thank you.
Thank you, Councillor. And Councillor Cook?
Yeah, thank you, Chair. I'm glad you've come to me straight after that question, actually, because my question kind of feeds on from that, because it's kind of related in not specifically autism assessment, but the wider implications on neurodivergent children and children with disabilities, thinking about the kind of needs analysis, and we've seen here a number of kind of key themes, and we had a breakdown, but I didn't see a lot in there about the specific needs of that demographic. So I'm thinking, for example, about things like links with community bladder nurses is in there, that kind of care. So are there kind of is there any breakdown in the profiles around the needs of those communities and that kind of impact? I think then a bigger question for me, Chair, if I can just ask my second one, is we've seen a lot in your presentation today and in the previous conversations around the procurement on an as-is basis, and that confidence to us that it would continue as is and then transformation would come. But I'm still not certain how we as HASC would then be involved in that part, how we could then kind of influence that, how we could raise perhaps any objections or concerns thinking about keeping things in Medway. And then a really technical one, if I've read this right on the papers and my understanding, there's some discrepancy between services being for children at up to 18 in Swale and 19 in Medway, if I've got that right. And if I have, how does that look in terms of the money? What happens in terms of consultation? Do we offer different things in different places? So just a bit technical, those three. Thanks, Chair.
Did you want to?
If I start on the consultation and the development of services going forward. So when I talked about our communications engagement so far, this first stage has been very general, trying to get the broadest possible views coming in to inform these next stages. And in the next stage, we get more specific and more specific as we start working with the provider to work through what those changes need to be for our population. So some of those quite specific questions about maybe the bladder and bowel paediatric service or specific autism services outside of this contract. But what we would do then is bring those groups together. And as part of that, in stage 2, we'd be looking to run a workshop with this committee and a separate one with the HOSC in Kent as well, to really work on what are those views of this committee that we need to include as part of that to feed into that service development. So then as we come up with the proposals with the new provider or the existing provider with a new contract, we will then be able to bring those proposals to this committee for that proper consultation. Mark, do you want to do?
Yes, go on then, Mark.
Thank you. So the transition, it was interesting because that was one of the things that was mentioned when we met with both the children's engagements and also adults. And transition doesn't just happen from children to adults, it also happens from adults to older adults. I think what we'd like to get to is a place where we have a consistent approach across the whole of Kent and Medway. But I recognise there are some details that we will need to work through. You're quite right, there is a year's difference between, I think it's MCH, HCRG and MFT. So already in Medway you have that discrepancy between the different services. So eventually we'd like to get to a place where it's 18 or it's 19 years across the whole of Kent and Medway. And if you go and speak to the patients and population of Kent and Medway, that's what they want as well. They want an easy transition, easy access to services. It's one of the things which we found, we certainly listened and heard the frustrations around some of the discrepancies in services that's delivered across Kent and Medway.
So we're really clear that we want to level up services to make sure that everybody gets a really clear offer and that offer is the best that we have already in the patch. There will, as Natalie rightly says, there will be a number of specific changes that would fall out of the improvements we wish to see over the course of this contract. And every single one of those we would wish to bring back to co-develop. But we don't know what they are yet, which is because we're starting with the as-is, but there will be a number of them. And we will go through the right involvement with our people, with the people using the service, and with yourselves for each and every one of those. But I don't know yet what they will be or in what order, but there will be a number over the course of the contract.
Sorry, Kate. I'm going to go to Councillor Wildy, but it's slightly concerning that statement. I'm confused by that statement. That you know, you was in a process that we paused, but you don't really know what's going to come back, and you're relying on HASC, which you will have to anyway under SB anyway. I don't quite understand.
So let me be a little bit clearer.
Yeah, can we have some clarity on that before?
Yes. We have paused the procurement process at the moment because we wanted to hear from yourselves tonight before we decided where we would go next. Once the procurement is done, I am really clear that there will be changes to those services during the lifetime of the contract. It would be very wrong to say there won't be, because many of them could be improved for the future to meet the evolving needs of our population and the evolving ability to provide care in different ways. And when we identify a change to a specific service within the broader umbrella of the contract, we will want to come back to you to talk about what the specifics of that change to that service would be.
And the provider and you would have to come back to us anyway if there was an SV.
Yeah, absolutely.
Because there'd probably be SVs on every one of those services when they're changing. So, okay, I've got it clear now. I know, because it'd be the provider and yourselves probably coming back, depending on what happened. Councillor Wiley.
Thank you. I have two general questions before a list of questions, but you mentioned a letter between our Chief Executive and Councillor Murray. I'm not sure that every councillor around the table has seen that letter, because I was sent it in confidence. I don't know about other members, but you referred to that. So that's, you know, some members will not be aware of that letter. You should be aware of that. I cannot understand. You know it's an SV because we've said it's an SV, and that's our right. You're going to do engagement and consultation by the papers. Where do you have difficulty with going through the process of an SV, and whatever those difficulties are, what would they be? And how can we help to smooth them out so that within an SV, everybody moves forward? Because these services obviously do need to move forward. As councillors, I'm sure we've all heard of some difficulties with some of those services, and I'm sure we'll hear of difficulties with the new services, whatever they are. But these services do always need to be continuously improved. I think we all agree with that. So what do you see as the possible way forward? Because if you don't see one, you wouldn't have paused, you would have just continued regardless, which is uppermost in your mind anyway. But how do you see us working together? What would be your ideal outcome?
So at the moment, we don't have any specific changes to talk to you about. There will be changes to services that fall within this bigger procurement, but as yet we don't know what they are. So I don't have concrete specific proposals to bring to you about what the service changes will be. What I would really like to do as we move forwards is to work with you on each of those specific proposals when we get them, in order to bring in the best services for the people that we all serve. But I don't have them yet. They will happen, because we are going to contract in a way that will make sure they can happen, because we very much want to be able to improve services. But as yet, I don't have any of those specific changes to bring forward to you.
So what is the difficulty of working the way you want to, but within an SV, to keep us, and through us, the general public, well informed?
So I think the difficulty at the moment is we don't have any specific proposals to bring you. because we're re-procuring as is, so we don't have any specific changes yet.
Sorry, Councillor Wiley, can I just come in? It's not.
Yeah, sure.
I've got to come in again. I'm sorry. I'm slightly confused here, Kate. Okay, because maybe and you know I know you certainly know your stuff, but officers have been here many times. You have a plan. You have a scope, and you know where you're going with that scope. It isn't good enough for the ICB to sit here and say you don't know what changes are coming and you don't know what the implications are going to be until we get there. Because, you know, that was one of the questions Mark will tell you, is that the reason I called him back, and I did call you back many times, and I apologise for that, was that we wanted to know your forward plan and your scope and what your plans were for doing this full procurement, including the very quick add-on of children's services, which you again said to us you have a full plan and a full scope for. We can't operate and comply if you're now coming to us here and your response is, I can't tell you what's going to happen. Because that is the whole issue with the relationship here with this SV, is that every time we ask you to come and to answer the questions, it took us a long time to break that wall down and get the detail we needed. And that's all we needed was the detail, the clarity and transparency. But here we are again with having this comment back. I mean, it's pointless us going on. It's pointless us going on this evening. Because you've got members here asking full questions about the implications and scope of this contract. A contract, and please correct me if I'm wrong, Mike and Mark and anybody else, a contract you fully scoped out, and either you've been here as well with me here. You fully have a plan. I'm told that Lee has a plan, Paul tells me you all have a full plan, and you know the implications of this plan. Yet we're getting that same pushback again, saying we don't know what's going to happen, we're not sure what's happening, we have to wait and see what... It's not good enough, Kate. It's not good enough for an organisation to run in that way. We're here talking about a really important procurement programme here, a procurement programme that this committee is really, really concerned about, but want to work with you to get to the end result. And all we're getting from a professional organisation is a comment saying we don't know where we're going.
So I think you're misreading what I'm saying.
I'm not.
So I am not saying we don't know where we're going. We are going to re-procure the services as is, and we are committing to improve them over the lifetime of the contract. We've shared with you our ambitions document, which gives some idea of the types of things we will want to see, but we do not have specific plans developed at the moment, because that will have to take place with the provider once we have relet the contract. And then we will work with that provider and with our communities, and we will come to you and say, this is the areas we'd like to improve. Let's co-develop that improvement together. But I don't know the specifics of what those improvements will be.
But with all due respect, though, Kate, and Mike, I can see you nodding, and Mark as well, your community service programme, which we delayed as well, made sure we didn't, and actually it makes us think to ourselves, it's a good job we did, because you're advanced on that, on elements of that. Forget the children's bit that you've just slipped in. You're quite advanced on where you're going with elements of the procurement programme. And yet, you're advanced, you have a plan. You can't tell me you don't have a plan. And you can't, and Mike, I'm going to look at you, because you're my interim on here. You're the one that liaises with me, as well as Mark. You can't tell me you don't know where you're going to go with these organisations and what the plan is going to be, and what the possible consequences of changing these contracts that haven't been changed for many years, like what the consequence is going to be. Because you would have to risk plan that, right? You know, you would have to have a plan for for you with your financial head on, you would have to also have a plan financially of where you're going with these, with what the fallouts might be on these different contracts and where it's going to end up. You can't come to us and say to us, you're not sure. And Kate, I know you're not exactly saying you're not sure what's going to happen. We know you're going to procure. We know you're going to procure. But for the risk element, you need to have an idea of where we're going to be on that risk. And I can't have the committee just be an answer saying, we'll come back to you. Of course, every provider will come back to you when we call it in for an SP or when we call in for a change of service. We know that. But what I can't have tonight, again, and hopefully we won't have it if we move on to some more questions, is we can't answer that. We're not sure where that's going to be. We can't answer that because what we're going to do is we've taken 10 steps forward and now we're going to take 20 steps back because we're going to be in exactly the same position we were before. I can't have the committee when I've asked for papers, I've asked for, and Councillor Wise, sorry, I will come back. I've asked for, your papers. After a while, we end up getting all your packs and we end up getting all your detail, which is really helpful. You should have given us the detail earlier. And then we won't be in the position we are again, because to me, it's all these questions, these open-ended questions that people are asking you, we don't seem to, either we're not asking the right questions or we're not connecting as a HASC and an ICB about this procurement process. And in the spirit of partnership, it worries the hell out of me because I thought we were moving forward, but we're obviously not moving forward. And I'm asking you as a group, again, please, let's have the transparency here because otherwise you're going to be coming back again and you're going to be coming back again and we're going to be saying to you, we're not happy with that. We're not happy with the way you're operating. And I don't want that. You know that. Mike knows that. Mark knows that, hopefully. I don't want that, but I'm not satisfied at all with the responses my committee's getting this evening so far. And we're only on question 3 or 4. And if we can't have the response, if you're not able to give us where your direction of travel is, we might as well stop the meeting now. Because if I get another response to a member that you can't answer, it's pointless. It's wasted your time and wasted our time as a committee. So I don't understand where we're going here. I mean, members, I don't know if you, Councillor Whitey or the opposition spokes, I don't know if you want to comment.
I can't understand how you're writing contracts or in talks about contracts and you don't know what you want from those contracts, which is basically what you've said. You must know what you want every service provider to provide, and you're nodding, so you do. So those details should be here. Now, they may be very difficult to get to some of those points you want to, but that's the discussion we should be having. And what is the point of asking a detailed question when you haven't got details, or you're telling us you haven't got details to where you want to go or basically how you want to get there. Now, I was trying to be conciliatory, which isn't my natural place to be at all, but I was trying and, basically I agreed with every word that Dan said. Yeah, so I agree. I don't know where we're going. And really, I would want to know for every contract what you want out of that contract, and then you can work out the details with the providers you need, etc. But surely that's the basis for starting anything. But yeah, thank you.
Shall I answer that? So at the point at which we let the contracts, we will be expecting to get the same services as in place today. So that's what we want from the immediate period after we've let the contracts.
And as Mark said, we've got 20 adult service specifications and we've got the same number of children's service specifications that have been agreed with the existing providers that we will go out to the contract with under that, and that will be the service that is contracted with to start with. We've also provided you as an appendix to this with our ambitions document. And that is going out to the providers as part of the procurement that says during the course of the contract, these are the ambitions and these are the direction of travel that we want to go in with each of those services. Now, we don't know the exact end point of that over an 8-year period of a contract. Those services will develop. We've got the Darcy report coming. We've got other things. So we cannot be absolutely specific, which is why we're saying at the moment this isn't an SV. And I know that that's different to what, I know that's completely different to what the council say. I know. But
Mike,
please let me finish, because I'll let you finish.
Sorry, Mike, I'm the chairman here for a start. You brought up the SV point. That's what I'm going to come back on you at. I will let you finish, but I'm going to remind you once again, for the upteenth time, that this committee, which is members made up of the whole of Medway community, have agreed that this is an SV.
Okay.
You can tell us how many more times you want that it's not, but this committee has agreed that.
Okay,
and from a democratic point of view, that's what I've told you, that's what this committee has agreed. Okay. But you can finish your point around, I don't think Councillor Wiley was talking about what's happening in 10 years' time or in 9 years' time. I think we were talking about the risk elements of where it's going at this stage. I don't think what Councillor Wiley was asking was a difficult question about how we would work under the SV. I don't think that's a difficult question, and we weren't getting to where we wanted to be on that.
Could I come in on the way we're going to move forward on this then? So to the original question around the way we really do want to work with this committee, we want to work with the people of Medway, the staff who are providing the services, to develop what those services are going to be. And for any change, we want to bring it back and do proper consultation, big C, that is supported by the engagement we've done. Now, we know the Darcy report sets out quite clearly a direction of travel, which is summed up sometimes with analogue to digital, prevention rather than treatment, and in the community rather than hospital. Those themes absolutely echo the direction of the health services. And what we want to do is work with local people, staff and this committee to work out what that means for Medway in terms of the services. So on day one, the services will be the same as they're provided now. What we want to do is work with you in the spirit of working together in consultation to say, so for Medway, over these next months and years, what is that service going to need to change so that we can meet the challenges which we're facing together for the people of Medway, and that's what we're committed to doing. And you've got a contract, but every year we go through a planning cycle that Mark will be able to describe, where we sit with the providers and set out what it is that we want to achieve that year. That will also be, any changes to that will be consulted with this committee and with the people. We have, what I can give you is details of the framework outline plan that we'll do as part of consultation, how we will engage with you, how we will engage with communities, staff and people to develop those service specs together. And we really do want to do that together.
Thank you, Natalie. And I have no doubt that you don't want to do, of course I know you want to, you've got to do this procurement. I get it. I'm not, you might think Mark and I might have the battle, but I'm not putting the wall up. I know you have to do the procurement. My plea to you is don't give us the detail afterwards. Don't, and Mark, I mean, hopefully you can back me up on it. I've said time and time again, this committee will work with you wholeheartedly with transparency. Not finding out detail afterwards, or not maybe like you just said, you can send us a document now. I'm not saying we wanted a document like this in this pack, but it's always when we get to the bottom of something, we have to then unravel when something's going to arrive and turn up. I don't understand it, and that's why you get the doubt from committee members. There's no doubt with the committee that, and I say it on public record here tonight, there are contracts that need to change. Desperately in Medway. I'm aware of that, 100%. You know, we need change. We need a good service for our residents. We need a good provision for our residents, and many are probably not getting that at this moment in time. Happy to say that. And you know that more than I do because you're working on the front line there. But however, we also have, I know it's not always popular, but we also have a duty to carry out here as a HAS committee. As I've told Paul, as I've told your chairman as well, with the arms out opening to say we'll work with you. But not every time we get a pushback and we can't get a straight answer, we go back, we move back, and we're not back at stage one, so don't worry. But what is the point of this committee asking you 20 or 30 questions tonight? There's no point. There's no point. Because we might as well send it to you in writing, and then maybe you can find the detail to send us the detail, because we're not getting what we require. Leanne.
Thanks, Chair. I mean, I think this boils down to, we know the why. There's an agreement as to the why. It's the how that there is a rub. Because for HASC and Medway Council in general, I guess there is a question about a leap of faith. So I'll give you an example. So tonight was mentioned about levelling up. That's a good thing, or, you know, trying to get some consistency. But I know members will be sitting here thinking in 5 years' time, how are you going to pay for that? Is Medway going to lose out to Swale, for example? It's all those little nuances that I think are getting in the way of this. So I think there's absolute agreement that things need to change. But it has been put to me that it's a peculiar way of going about it. And I think that's what this committee, on the whole, grapples with. So, you know, Chair, you can say, what is the point? I think there is a point, but I've offered training. We had a very good training session the other evening. I think it really brought things together. But I really do think it's time now that officers got their heads together, because I don't think this is the arena that we are going to resolve this in. But there is certainly a gap, a wide gap, about the how. Thank you, Chair.
Could I come in, Chair?
Natalie.
Just to say we recognise that there is a need to build some trust and build the relationship with this committee. And just to say we are really committed to that moving forward. And I think that is the commitment that we're all giving here, to make sure that this committee is properly involved, engaged, and where appropriate consulted on these changes, but recognise that we have a distance to travel and we're further apart tonight than we would like to be.
I mean, I think, Leanne was correct around the officers' part. I mean, at some stage you are right, Leanne, but it will have to still come back here. And, you know, I'm not going to say we're back to stage one, because we're not. Okay, Ivor, do you want to come in quick? Come in.
Yeah, if that's possible. So I'm sitting here reflecting on a few things. One, just to touch on money, and the money that I can touch on in this bit, and we can go into a bit more detail later. The commitment in there, and I didn't explain it very well, was that we were fixing the ambulance as a minimum for 5 years. So there is no expectation for us there'll be any reduction in funding spent within Medway to go to anywhere else. And actually, when we look, I think we'll be levelling up to Medway and Swale levels, particularly Swale, actually. Swale has greater funding than the Medway locality at the moment. So we deliberately, when we looked at this, said we were going to be levelling up, which is increasing the spend. I think the bit for us, it's been mentioned a few times, the DASI review, I think in the NHS we'll be putting more funding into community services. As an ICB, we've committed to shift through our primary care and out-of-hospital strategy, more money into out-of-hospital. We are having an ongoing debate whether that's taking it out of acute services into community, and to have that, ideally that's where you would go, but we recognise we have to invest in community and then see what happens to acute, rather than take the leap of faith that you're talking about in some of these, because patients will still go to hospital. So we will be investing more money into community. I don't want to labour the point and annoy you, but we don't know how that will be yet. We haven't got the Darcy review. We don't know how we know our journey, but we don't know the answer. I think the other bit for me is whether there is a conversation we need to have separating the service development, which will be designing and working with populations, with the patients, with their carers, and you, as we develop those along with our ambition strategy, and whether there's a separate contract conversation that maybe we have in part 2, because I think I'm getting confused about the difference between the two here.
I won't worry too much, Ivy. I don't get annoyed that easy, so I'm okay. You'd almost say, although Mike would think I'd get annoyed, I think you almost say I'm passionate about health and about the change and about, I'm going to say I'm quite excited about a change in direction and a better service for our. We're not achieving it. That I think the biggest issue here, and maybe we do take it away, maybe it's me, opposition, maybe vice chair, opposition spokes, whatever, and officers, because the biggest issue here is there are some members of the ICB that are not accepting the SV, right? And every time we're going to push back on the SV, we're not getting anywhere here, because as a committee we agreed an SV. And whether, not everyone that leaves the table when they get an SV is happy. But actually, I've said it again, and I said it to Paul, look back on the last meeting, use it as a positive, and we work with you and work in partnership, not against each other and hiding. It's not about that. And it's really sad that we're back where we were. Councillor Wiley, and then we'll tie this up, I think.
Right, thank you. One of my questions was, how can we move forward? I cannot see your problem with an SV because you talk about consultation and engagement, and then reporting back to this committee, which are the main focus of an SV. You talk about whether it is or isn't an SV. You brought a report to us late and with bits missing, and we can talk about, but you brought a report to us which asked us whether it was an SV or not. So at that stage, you know very well that was in our decision-making powers. And that's what we decided, because it obviously is a major change. So I cannot see why we're still arguing about that. But if I can go back to my original question, how do you see that we can move forward with sensible consultation, coming back to this committee with more detail? That must be possible.
So just for clarity, we have absolutely heard that you believe this is an SV. We accept that, we've absolutely heard it. We don't have any specific examples of changes to services that we wish to make at this point because we're procuring on an as-is basis. So I cannot give you more specific details beyond our ambitions document, which you've already seen. How we could move forward, my question is, what would you want to see next? Because we can't come and describe to you changes at the moment because we are procuring on an as-is basis, but being really clear that during the lifetime of the contract we will expect to see change, and when we know what those changes are, we will come and develop them with you.
So Kate, you've all mentioned about the new legislation, the Darcy report, etc. So under new procurement legislation, since January 2024, you are able to, under Category C, make direct awards, right? Are you saying no, Mike? Are you saying no for that, for new legislation?
There are a number of ways of procuring. Oh, sorry. There we go. There are a number of ways of procuring, and we've been having conversations with our legal team and also with NHS England around the most appropriate way. And for us, the most appropriate and lowest risk way of challenge is to go to the route we're taking around a market approach.
But as is, with your providers, as is, you can make a direct award, right? Under legislation, you can.
Not without challenge, you can't. We've got a private provider whose contract is coming to an end. We've got a community interest company, the contract hasn't been renewed for a long time and has been rolled over. There is a market out there. We would be open to legal challenge if we did a direct award. We currently, as the paper says, already have 5 providers within the market within Kent and Medway. Any one of those could actually challenge to say that we were making a direct award within the area. So our legal advice and our procurement advice is that the most secure way and the most appropriate way would be to go out to competition.
So those that are satisfying their contractual obligations, you can do a direct award, Mike?
If there is no other alternative provider out there?
Or if they're satisfying their contract?
And if there is no other provider out there, if we are at the end of if you are with our private provider, with a community interest company, where it's coming to the end of a contract, we have to make a decision as an ICB as to the legal compliant route and whether or not we will get challenged by other providers for not opening up to the market.
But you do agree under the new legislation from January, you can, if they're satisfying, if you've got a contract that's satisfying its obligations, you are allowed to do a direct award under the current legislation on Category C.
So,
because I've read the rules, that's what it's saying.
But our advice is that would be an unnecessarily risky way forwards, and we've been advised that we should go with the provider selection regime. So that's why that's our proposal.
So it's not necessarily as is then?
No, it's procuring as-is services. The specs are as-is. The procurement route is by the provider selection regime. But what we are procuring for is the same service specs that are in operation today.
But the providers and the service may not be as is?
No, the service will be as is. That is what we are procuring for.
Yes.
Okay.
We're providing as is, and we would be open to threat of litigation from other providers by not going out to the market.
So this is, I mean, I'm going to hand over, I'm going to hand this to carry on with Leanne and moving forward on this. But I suppose this is the issue, isn't it? Because we're looking at as is, then you're talking about transformation and having brand new contracts and doing things in a different way and making it better and providing better for our residents, which I don't doubt, right? It's not as is it?
But it is as is.
Okay.
It's what we are awarding is an as-is service spec. But we are being really transparent and open that we will not sit and let it be that same as-is service spec for the whole 8 years. Yeah. We will expect improvements.
But my challenge was around you know, I understand your own legal challenge. Sorry. I understand your legal challenge, but you know, from the new rules, you can do a direct award. Leanne, I think where we are now at this situation is probably it'd be opposition spokes, vice chair and chair and officers working a way forward to present properly here what needs to be done for members, because we've stepped back. We haven't stepped forward here this evening. Councillor Lane, did you have a point to make, or not a question but a point?
Point, because it seems like I'm a bit getting confused, because if from the way they are speaking, that means that there is no any transformation, there is no improvement. So if there is no transformation, there is no improvement, that means that they are going back to the services that is already in existence from what is going on. So I don't think there is any for us to be arguing or going forward with that, because it's the same old services. That's from what they've said, and from the definition of as is means that there is no improvement, there is no modification.
Thanks, Councillor. Leanne, are we going to take the action for Leanne? Is that okay, members? We have to take this out of the room, and with officers and with opposition spokes and myself and vice chair to see the way forward for this. Councillor Brown?
Will we be able to get the answer to some of the questions that we've asked? I definitely agree. It's a way forward if officers get their heads together, because we've got some finance questions with an answer different tonight than we got from the Chief Exec. And we've also, I don't know how, if I were bidding for this contract, how I would how I would cost the transformation if I haven't got a proper spec for it. But that's just a comment.
Thanks, Councillor Brand. And you are right, it's pretty different to what we heard the other week. But I feel we need to try and move forward because otherwise this is going to carry on. You know, from my point of view, we're not happy with the way forward at this moment in time. That doesn't stop you going off and doing what you need to do. But we would still look at how we would probably challenge that. And that isn't a good way of working, is it? We need to close into a room and just bang our heads together or bang my head, whatever you want to do, to get a way forward here, because this is going on too long and you know, no good for you. But every time this happens, the relationship moves significantly in the other direction. And that isn't what I want, and that isn't what I want from this committee with you, with any of you. But that's where we are at this moment in time this evening. And it's really disappointing, I think. And probably just for a few little bits that could be more transparent. That's what I think we are. Mark, did you have anything you want to say? Or?
I think we're being as transparent as we can be.
Okay.
And certainly, you know, from my contact with you, that we've not held back and I've given you as much information as we can. And I echo what Kate said. The basis for those new services are the as-is, and then in the future years we'll address the health inequalities and the access, all of those things that I heard from the patients of Medway say, please can you change some of those services. But you're right, we're going to be here in another 2 months' time and another 2 months, and as I keep saying, we need to do something. We need to work with either new providers or the current providers to transform and change those services. The patients need that, they want that, and I think you're right, we need to get ourselves in a room as quickly as possible and get this sorted out, because it's causing detriment to patients at the end of the day.
Yeah, I mean, transparency is you know, I didn't say trust, I said transparency, right? Councillor Amadishi.
Thank you very much. I think, just to echo what my colleagues are saying unanimously across the board, this is the first time in all my years in transformation I've heard of transformation with no to-be process. Everything is as is. So when the constituents of Medway hear such sentiments and they know that as is so poor as it is currently, there's no to be. You know, the ambition doesn't match a vision. You know, so I guess you need to work backwards in a sense of what is the actual vision we're working towards, because procuring as is now, which is really poor, is not going to push the level up. It's not going to inspire any hope for anybody in Medway at the moment. So I would want more detail. As everyone said, I don't want to go around in circles, but certainly in transformation, it works like this. 5 years, you've got to talk about the changing workforces, managing that change. By the time you move to reflecting and then modernizing your service, you're talking about the 4th and 5th year. So basically what you're saying currently, the current thinking is in year 4 or year 5 of this new procurement, then residents are potentially going to see a transformation. And I don't think that's good enough. I think that's where the shaping of this document needs some refinement and discernment to get it to that stage.
Thank you, Councillor Amadishi. Look, I think we're move ahead with what we just said. I feel I do take on your points, Mark. However, you know, maybe some individuals need to also walk away from here and take on the points about not battling around the SV part. Because otherwise we will be back here in a month, 2 months, 3 months, because it's you know, we've all got to be respectful of each other. And the committee structure has a purpose, whether it's liked or not. So, you know, if that's keep being pushed back, you're going to keep getting pushed back from this committee. And the last thing, you know, we certainly won't have that transformation and the procurement and the quick add-on of children's services thrown onto this committee for the detriment of this community. The ICB would have to look at themselves for that, okay? I'm not having the committee blame for that. Not for quick firing in, slipping in, firing in at last minute, procurement like, children's services being thrown in at last minute here in Medway. But we're willing to work with it and willing to get the transformation and what we need. Vice Chair, it's very difficult for you, I think, because we've thrown a lot in.
I'll try and do my best. I move that this committee takes this matter of the procurement and service transformation from the ICB out of this committee for now, under the leadership of Leanne, to bring council officers and ICB chair, vice chair and opposition spokes together to have a discussion about what the next steps are so we can proceed with this. Sorry, and George Crozier from the Independent Group.
Yeah. And also, if you're in agreement, we'll send the questions over to you what we had. I think there's around 25 or 30 questions. And hopefully you'll be able to get the response back on that. And we'll have it on the briefing paper for everybody. But we'll send you over those questions via Terry. But, there is some reflection for all of us, I suppose, even ourselves, but, yes, it isn't where we want to be. And it's unfortunate. We'll get there. Okay, we'll take it offline. Leanne? Yep, you second it? Okay, members agreed? Agreed, thank you. Thanks very much. Thank you for your time. Thank you. Terry, on that note, can we move to the work programme really quickly, please?
Thank you, Chair. Just a very quick minor thing from me. I just wanted to refer, there's a reference in the report about removing the impact of immigration policies from the next meeting. One of the officers responsible has offered to provide a briefing note, which I assumed members would be supportive of. So just to make that point in there. There is some stuff around development between for HAS members. Leanne and I ran a session with the ICB last Wednesday, and we talked about maybe doing some development sessions with them, which we will build in at some point when that's appropriate. So just to let you know about that as well. Thank you.
I move that the committee notes the report and agrees the work programme as set out at Appendix 1 to the report, subject to accepting the proposed changes outlined in italic text on Appendix 1.